Hello, good evening and welcome everybody on behalf of Wither Ophthalmic Society and Ophthalmological Society Nagpur. We welcome you to this webinar on mucormycosis, the black code, which is now very rampant everywhere. We have got very eminent faculty today with us. Before we start our session, I would like to request Dr. Ashish Tul, President of BOS, to please welcome everybody on behalf of BOS. Ashish Tul, sir.
Thank you, Viral. Good evening, friends. The topic for today's discussion really is a very hot topic, mucormycosis, a misnomer actually, black fungus, but we have to use that word to kind of let the public relate to it. No, on the one hand, there's a lot of panic amongst the public because of the dreaded nature of the disease. So our job as medical professionals is to try and reduce that panic. And as far as our fraternity goes, we need to get ourselves well versed with the specifics of the disease, in the sense how it presents to various specialists in our practice. As ophthalmologists, specifically what things we need to look for, and how we can advise our patients to take preventive measures. We have a very eminent panel with us today, all doyens in their particular specialties. And I am sure we all, at the end of this session, this webinar, with the talks by our expert panel, expert speakers, and the discussion that would follow, wherein our expert panelists will also contribute, we will all end up getting good learning points, which will be useful to us in our practice in dealing with this dreaded disease. So thank you so much, and looking forward to a great webinar. Thanks.
Thank you so much, Ashish sir. Ashish, under the leadership of Dr. Ashish Tul, this year we have taken this national webinar series. Every month we are involving one district ophthalmic society and taking a topic of interest for the general ophthalmologist for this national webinar series. This month, we have associated ourselves with Ophthalmological Society of Nagpur. So I invite President of Ophthalmological Society Nagpur, Dr. Mona Mujumdar, to please say a few words. Dr. Mona. Yeah. You are muted. You are on mute.
Now, is it okay?
Yeah.
Yeah. So I welcome you all on behalf of Ophthalmological Society Nagpur. Mucormycosis has really created a panic situation. We can't go back and change the beginning, but we can start from where we are and change the ending. And with the guidance of today's speakers, and with the vast knowledge they have, I'm sure with their help, we are going to get back to normalcy very soon. So I won't take too much time from this webinar and allow the masters to speak instead. It is an honor to have all of you. Over to Dr. Viral.
Thank you so much, madam. So now all our faculties and chairpersons have joined. So for today's session, we have got chairpersons Dr. Prashant Agnihotri sir and co-chairperson Dr. N.D. Patil sir. Moderator, we have got Dr. Shivani Bide and convener Dr. Neha Deshpande, coordinator being Dr. Rahul Tiwari. We have got an esteemed panel of panelists, expert panelists with us, Dr. Prashant Bawankude sir, Dr. Gopal Arora sir, Dr. Rajesh Joshi sir, Dr. Milind Changole, Dr. Ashish Kamble, Dr. Sandeep Anjankar, Dr. Ashish Sapkar, and Dr. Saurabh Agrawal. Our esteemed faculty for today's program, Dr. Sandhya Sahuji Madam, Dr. R. Ravi, Dr. Madan Kapre, Dr. Milind Naik, and Dr. Nitin Shinde all have joined. So without wasting much time, now I hand over to the chairperson, Dr. Prashant Agnihotri sir, for further proceedings. Prashant sir.
Thank you so much, Viral. It's been an honor that I've been given this responsibility of chairing such an important session. And I'm very happy that I have my co-chairman, Dr. N.D. Patil, and the host of faculties and the moderators and others which you already introduced, so I won't take time. Well, friends, last 1 month has been really a roller coaster for us to try to understand what is happening I mean, we were trying to come out of this dreaded COVID, and then we are hit with another pandemic, another epidemic, I should say, which is mucormycosis. As Ashish said, it's basically a blue fungus. It is ubiquitous. It is present all over us, all around us. We are breathing spores, but it doesn't affect so easily. It's because of the resistance. So why this time we are getting so much of mucor? There are many reasons, and I have whatever little I could assimilate was that there are few factors which are different than last time. It's not that the last time there were cases, but there were not so many. Probably a couple of things which I could assemble is that this virus strain, this is a mutant strain, and this mutant strain is different than what it was last year. So probably that is one factor. Then there is another thing is that it is happening to most of the people. Now, I'm not saying all who are not vaccinated. So that is a strong point in favor that we must encourage all the people to get vaccinated. Just, create this data, whether people who are getting mucor, they were vaccinated or not. And the third thing, which I have, I think, and which Madan, Dr. Kapri would be able to highlight, is that amount of steam inhalation we do. Anybody who gets gets a COVID, it's only hourly steam inhalation. Now, what does steam inhalation do? It destroys your cilia, it destroys your nasal mucosa, and it makes it more prone. Actually, all this, that oxygen, the tubings and all, probably they are more of a human minds venturing into various gases. But I think to me, these are the things which I could say that mucor is susceptible, it makes you susceptible, and more important, the dysregulation of the immune system. COVID does dysregulation. So what can we do? I think the only thing as an ophthalmologist I would suggest and I would recommend is early detection, and early detection. And what are the signs we should look for? Pain, a neuralgic pain. This pain these patients have is such a severe pain that it does not let you sleep. So tell your patient, if he calls up that he has a pain around the eye, ask him, can you sleep with the pain? If you cannot, you should come immediately. Second thing is swelling ipsilateral, whichever side the pain is, that's second factor. And the third thing is the patient with visual dysfunctions. So probably with this brief introduction, I would like to hand over this mic without taking much time, that let's try to understand what more we should know about mucor, because we were only knowing that exentration. Now things have changed. It is the endoscopic surgeries have come in. So I'll request Andy Patil to take over, and he can start calling the speakers, introducing them, and let's go ahead and let's have a very interactive session and enjoy. Good evening to everybody. Over to Andy Patil. Andy?
Thank you very much, sir. Thanks a lot for giving the initial introduction for this. And to demystify this mucormycosis, we do have the enlightened faculties who are going to enlighten us from various departments. Dr. Sandhya Sahuji is going to tell us something about the microbiology, Dr. R. Ravi to tell us about the pathology, and Dr. Madan Kapre, the renowned ENT surgeon, he is going to tell us about the his field, and Dr. Belen Naik is from LV Prasad Institute, and he is going to tell us about the ophthalmology and ophthalmological management of mucor. And another eminent personality is from infectious diseases, Dr. Nitin Shinde. He is going to tell us about the various infectious management is involved. So I would like to invite first Dr. Sandhya Sahuji for her talk, and I will request to introduce her. Yeah, Dr. Neha. Yes, please.
So I'm going to introduce one of the most, you can say, sincere clinicians I have seen, Dr. Sandhya Savji, who has done her MBBS and MD microbiology. She's at present consultant microbiologist.
Can you come on the screen by tapping your video?
Sorry?
That's it.
Okay.
That's it.
Okay, thank you. So she is a consultant microbiologist and lab director of Suvishwa Diagnostic Lab, Nagpur. She's running her own specialty high-tech microbiology lab. Her experience spans for almost more than 20 years. She has also been ex-president for Vidarbha Association for Microbiologists, and she's also advisor for infection control committee of many hospitals in Nagpur, including ours. And I have always liked her enthusiasm, because whenever you send sample, we will always get a call. Can you tell me clinical history about the case? And you are also excited, because you know the microbiologist is also getting involved in giving you better diagnosis. So Savji madam, over to you.
Welcome, Sandhya.
Thank you, sir. Thank you, ma'am, for kind words.
You can share your screen.
Yes, I'll do that.
I'll request the speakers to please stick to time so that we have a lot of time for interaction. We'd like this to be a very interactive session.
Yes. First of all, I thank Dr. Ashish sir, Dr. Viral sir, and organizers for inviting me for this session. I'll be talking on microbiological profile of COVID-related fungal infections. Every one of us know about the pandemic of COVID-19. It is an emergency global public health problem. SARS-CoV-2 is a highly contagious virus. It affects mainly the respiratory system, causing acute respiratory distress syndrome and viral pneumonia. It causes diffuse alveolar damage and severe inflammatory exudation. In this COVID era, we are facing mainly many fungal infections, and we are mainly aware of mucormycosis. But there are many other fungi that are active during this era and causing infections in patients. But the symptoms of invasive fungal infections, they are mimicking to that of COVID-19, that is fever, breathlessness, cough, etc. With the aggravation of disease, it is easy to attribute severe symptoms to the COVID-19 and to some extent to the bacterial infections, which are empirically treated with antibacterial treatment. But clinical suspicion and diagnosis of fungal infection is usually delayed, which further complicates the disease. So what are the predisposing factors? Viral COVID-19 viral infection itself, it causes the immune system dysfunction. And other factors in India are diabetes mellitus. India is a hub of diabetes. Then malnutrition, and other factors are renal failure, malignancy, immunosuppressants, and many. So the common fungal infections which we encounter in daily practice are mucormycosis, then aspergillosis, the candidiasis, and other infections which are not very common in India, but other filamentous fungus are there in our area. So mucormycosis, everyone is aware, because it's very prominent presentation causing facial pain, because it involves the upper respiratory, mainly nose, paranasal sinuses, orbit, eye. So the symptoms are very obvious and we are aware of that. But other fungal infections, they are mimicking viral pneumonia, so they are usually missed. So what are the common infections? They are mucormycosis and aspergillosis. The fungal infection, they are characterized by rapid progression, high morbidity, and mortality. Mucormycosis is caused by the group of fungi in the order Mucorales. The main fungi in this group are Mucor, Rhizopus, Absidia, Cunningham-Mela, Succinia, and few more. In Aspergillosis, the common Aspergillus species are Aspergillus fumigatus, Aspergillus niger, and flavus. These Fungal infection, they are mainly caused by inhaling the spores. They are sporangiospores released from the fungus. They are very tiny. You can see in the picture, they are numerous in the background of this sporangiophore. They are readily dispersed throughout the environment. They can be found on all human surfaces which are in contact with air, especially upper and lower airway mucosa, and they are easily aerosolized. So in the pathogenesis, the source of infection is are fungal spores. The portal of entry are inhalation. They mainly lodge in the nose, paranasal sinus mucosa, and lungs. Other routes of inoculation, infection are inoculation, gastrointestinal infections, and disseminated. In aspergillosis, the increased incidence of aspergillosis is seen during COVID patients. They are COVID-associated pulmonary aspergillosis or kappa. It occurs mainly in severe COVID infections. Non-specific symptoms are there. It requires deep lung secretions for testing. Delayed diagnosis causes high mortality, and the common test to identify a fungal culture and galactomannan testing. Other infections are candidiasis. The Candida auris is emerging pathogen in healthcare setting. It survives in a hospital environment and very difficult to eradicate. It spreads rapidly to produce invasive disease. It mainly colonizes the various lines like central line or urinary catheter, intubation tubes, and rapidly produce invasive disease. The predisposing factors are limited availability of gloves and gowns during and reuse of these items during this COVID pandemic, and changes in cleaning and disinfection practices have become prone for this infection. Candida auris is usually mislabeled or misidentified in laboratory routine tests. So their spread occurs very rapidly because preventive measures cannot be taken because of misidentification or mislabeling. And it is this Candida auris is multi-drug resistant. It is resistant to main 3 antifungal group. Coming to the lab diagnosis, in filamentous fungus like Mucor or Aspergillus, inhalation of sporangiospores is through nose. The spores they lodge in nose and paranasal sinuses. And upon germination, this infection may rapidly extend into adjacent tissues involving palate, paranasal sinuses, orbits, and cranial to brain. So the biopsy or scraping from this area is very important material to give the diagnosis, and these tissues are highly recommended. Tissues can be obtained from paranasal sinuses by endoscopic or surgical debridement. Then bronchoalveolar lavage is required in case of suspected pulmonary involvement, especially in case of aspergillosis. Then blood culture, urine culture, or site-specific sampling is required for candidiasis. So these are few pictures of specimen which I received in my lab. In first container, it's a biopsy. It's collected in sterile saline, and these are the scraping from the crust, which are also helpful to give the diagnosis or to identify the organism. Then swabs collected are not recommended because the swab from palate, oral mucosa, conjunctiva, nasal swab, they are not recommended. They usually produce scanty material which in which the possible causative agent is usually missed, and it gives false negative result. So for the primary identification, direct microscopy is recommended. It's a key investigation. It is simple and rapid. And there are two types. First one is KOH mount and another is fluorescent microscopy. Both are very useful for the direct microscopy and rapid diagnosis of fungal elements. 10% potassium hydroxide is used for direct microscopy. This potassium hydroxide dissolves the tissue, making fungal elements more prominent. These are the slides prepared for cabbage mound. On microscopy, we can differentiate these two fungus to some extent. Mucor species are thin-walled ribbon-like, little wider and hyaline hyphae, which has wide-angle branching. In Aspergillus are thin filaments around 3 to 5 micron wide and regularly septated with dichomatous branching. These are few pictures of sample or fungus which I received in my lab. This is a mucor. You can see the hyaline hyphae. They are very thin-walled. These are the sporangiophore present in the tissue. You can, this is Aspergillus slide. You can appreciate the thin, narrow filaments, small, delicate filaments. This is a net picture of immunofluorescent microscopy. By using fluorescent brightener like Calcofluor white or Blancophore, this immunofluorescent microscopy can be useful to find even the smallest fragment of fungus present in the specimen. This dye binds with the chitin of fungal cell wall and fluoros in ultraviolet light. These are few pictures of culture. This is again mucor, young culture, white candy-like structure. The sporulation has started that changes the color to black. This is the culture microscopy picture of mucor. The sporangiophore bears round, thin-walled, large sporangia which rupture to release sporangiospores or spores. This is actually a tissue microscopy slide. It shows presence of spores in the tissue also. You can imagine the extent of infection in this case. The sporulation has occurred inside the body. This is the Aspergillus culture. There are two different species. These are the different Aspergillus species reported in my lab. This another is penicillium. It's a culture and microscopy which is also isolated from bronchoalveolar lavage. For the species level identification of many Candida and mucor, multi-top mass spectrometry and other automated systems are useful. For Aspergillus, culture microscopy is usually helpful to identify the species. In most of the cases of mucor, species level identification is mainly for epidemiological purpose and to investigate the outbreak. For treatment management, genus identification is sufficient. For antifungal susceptibility testing, for Candida species, broth microdilution and e-test are useful. And for filamentous fungus, it is done only in few cases of treatment failure. It is not done routinely. These are two microphotographs of histopathological slides. First slide is of mucor, and these are the Aspergillus filaments. Molecular tests are also available to very limited individual tests for either for individual test or panfungal test are available, but not in our area. PCR test can be done directly on tissue or ball specimen. It has high specificity but varied sensitivity. Then the antigen biomarkers. There are two antigens available. 1,3-beta-D-glucan.
Madam, please continue.
Yes. Just one slide. It's a part of cell wall. Its presence indicates a fungal invasion, but not particularly to any single fungal species. About galactomannan, I have received around 207 serum samples in my lab in the period of 4 weeks, and in that around 37% was the positivity rate. We are aware of only mucormycosis, but other fungi are also present to noticeable number. So awareness of the possible fungal co-infections in COVID-19 is helpful to prevent morbidity and mortality from these infections, because every life is precious. Thank you.
Thank you so much, Sandhya. I just want to have one question before we go to the next
Yes, sir.
talk. How much is the duration you require for confirming the diagnosis? Because the fungus start growing so fast.
Yes, sir.
We'd like to know what is the minimum time you can report it back.
Sir, for KOH or microscopy, maximum 2 hours are required.
2 hours.
Before that,
that's
yeah,
it.
before that, also I have reported. But
That's
fungal culture takes around 24 to
No,
48 hours.
at least, you know,
Yes.
KOH stain, we can
Yes,
get
sir.
the information. Yes,
Yeah.
Andy, we can go to the next talk now. Please unmute yourself. Huh?
Yeah. Now the next talk is
Thank you so much, Sandhya.
Dr. R. Ravi. May I request Dr. R. Ravi, but before he starts, let me say a few words. As far as Dr. R. Ravi is concerned, he is very well-known pathologist from the city of Nagpur. And he is specially invited for this meeting because he is having the experience of more than 150 cases of mucormycosis. He is seeing day in and day out. And one more thing, especially for as far as we ophthalmologists are concerned, he is going to present very interesting finding from the accentrated eyeball or whatever the specimen he is seen for this. And one more thing, especially, I would like to emphasize that since he is very much interested in the field of histopathology, fine needle aspirations, and cytology, he has presented many papers in the national forums, and he is the most sought after faculty for various meetings and conferences. He has introduced one interesting thing is that even how to do the how to tell the surgeon that whether the margin is clear or not, even though you don't have the frozen section facilities. In that situation, he has presented this paper, and which is very interested, and for almost all the surgeons who are involved in the tissue diagnosis, we can have with Dr. Ravi. And since he is the faculty almost everywhere, including the Madhya Pradesh. And he is doing outreach services also for Melghat, and he is the faculty for thyroid camp conducted by Dr. Madan Kapre and R. Ravi as a pathologist. So I would like to invite Dr. Ravi, but before that, I must say he is very well versed with the classical music, and the way he is saying Sher and Shairis, mesmerizing the masses. We may listen few couplets if he is inclined to. Okay, let us go to Dr. R. Ravi.
Thank you very much. Dr. Andy is a very close friend. Hello?
Yes, sir, we can hear you.
We can hear you.
Yeah.
Yes, sir, we are hearing you.
Yeah, I know. So Dr. Andy Patil is a very close friend, so no wonder he speaks very high about me. I am like any other pathologist. And Dr. Sandhya has very nicely covered most of the part, and there is going to be some degree of overlap in what I am going to talk and what she has already spoken, but then I'm going to stress more on my histopathology data of Mucor, which I have seen recently. Actually, we belong to a place we call ourselves an Institute of Surgical Pathology, and we have been doing a lot of oncology work and a lot of surgical pathology work. And till till recently, we were seeing Mucor, say, once in 2-3 months or maybe 3-4 months, and was not very commonly seen unless patient was diabetic or patient was on chemotherapy or patient was immunocompromised. But suddenly, in the month of first week of March, we suddenly started seeing more and more Mucor, and we realized that we are probably facing an iatrogenic epidemic of Mucor. And what is Mucor? Like Sandhya has already told, Mucor is a fungal infection caused by Mucorale order, and one of the commonest species we are seeing is Rhizopus, Absidia, Mucor, and other. And the cases which I have seen till now and still seeing are almost 202 cases. And average age of my patient has been 56, the senior most 73, but I have also seen younger patient like 12 years. Not only that, recently I saw a patient of PCOD and who became diabetic during the treatment of COVID. And then her blood sugar was almost 490, and she also was having Mucor. So it was really very much worrisome that people are getting Mucor at the drop of the hat. These are broad, non-septate fungus, asymmetrical, and there are usually many neutrophils and histiocytes within the necrotic granulation tissue. Sometimes we start seeing granulomas also. Association with hyperglycemic state, diabetic ketoacidosis, and immunosuppression is very well known. And it usually spreads rapidly across the nerves, tissue planes, to blood vessels of the orbit and brain, and causes thrombosis, hemorrhage, and infarction. Mortality rate at times has been reported as high as 48%. The diagnostic methods, like very nicely told by Sandhya also, that there are rapid methods like biopsy, KOH, and also a fluorescent stain. But Mucor is not exactly very easy to culture, but like people like Sandhya are doing very good cultures. But what I would like to tell that biopsy remains the mainstay of diagnosis. See, I belong to an era where we were also microbiologists when we did our post-graduation. So I can tell you that KOH, etc. does help, but then the histopathology is the investigation of choice to pinpoint the diagnosis of mucormycosis, because it is very also, you can assess, difficult to assess location also can be biopsied. And histopathology nowadays take not more than 12 hours to make a diagnosis. Like if I get the sample in the morning, very next day morning, I can tell, yes, this is Mucor. The fungal forms of Mucor are broad, non-septate, and they are wider than Aspergillus. Like Sandhya told, that Aspergillus is also very common because in this COVID era and also in immunocompromised state. So one has to know the difference between Mucor and Aspergillus. And angioinvasion, intravascular thrombosis, marked inflammatory reaction are the features of Mucor, and usually patients of COPD, etc. have Aspergillus. So one should be very much aware that maybe they are also dealing with Aspergillus because the treatment plan is totally different. There is not many good biomarkers for mucormycosis, and we don't have time for the biomarkers because we have to give a report maximum within 24 hours. Negative galactoman test does rule out other mold infection, but then one should remember, clinician, that a false positive galactoman test can be there in patients who are on piperacillin and tazobactam, and this can lead to an erroneous diagnosis of invasive aspergillosis, because galactoman is a test mainly done for aspergillosis. Distinguishing Mucor from bacterial infection is very important because from bacterial infection and aspergillosis, because treatment with at times in suspected aspergillosis can increase the pathogenicity of Mucor and with obvious dire consequences. Of course, like repeatedly we have been telling, pre-existing disease. In our series, most of the patients were hyperglycemic, previous respiratory pathology, systemic immune alterations of COVID-19 infection is also very well known. And it does lead to secondary infections, which are increasingly being recognized in view of their impact on the morbidity and mortality of COVID patients. There is a paper from PGI Chandigarh that Mucorales spores are found everywhere, even in hospitals. And this paper is from 2016 from PGI Chandigarh. And so now obviously this mucor is present everywhere. So we have to be very careful in treating our patients of COVID. I like do even Giemsa stain, even sometimes, like, you know, every pathologist is more comfortable with whatever stain they use. This is Giemsa stain. In Giemsa stain, it takes me only not more than 8 minutes to make a diagnosis of mucor, and you can see the mucor. Or sometimes we do a fast HND, which takes about 10-15 minutes, and hematoxylin eosin also we give a diagnosis of mucor with a lot of confidence. And in fact, I also do PAS stain, that is periodic acid sheaf, which is very diagnostic, or rather quite diagnostic in making a diagnosis of mucor. These are all done in our own setup, and which we within couple of hours we tell the clinician that yes, you are dealing with mucor. But then cytological slides at times are not very helpful, because if you see it, fine, good, but if you don't see, then I wait for the small bit, I take it in formalin and wait for 24 hours and tell the patient that the final report will be given next day. And of course, like this being an mRNA virus, the COVID virus, there is immune dysregulation, and this immune dysregulation, like there is CD4 and CD8 tells are altered, and this leads to altered innate immunity. To some extent, see, I have been doing a lot of work on HIV also. This virus at times does behave like an HIV virus, mRNA virus, and selectively it creates problem in patients, causing immune compromised state. This is my own feeling, but then it does affect in some individual by causing T-cell immunity dysfunction. Of course, this is the pathogenesis of how it works. One need not go into detail. What is more important is polymorphonuclear dysfunction and impaired chemotaxis. This is because of diabetes. This is because of serum iron, which is high in these patients. Iron is very important for mucor, and corticosteroids themselves can cause impairment in neutrophil migration. This is one of our histology, which is showing mucor. You can see the mucormycosis in the arrow. This is necroinflammatory background with mucormycosis. And this is a slide showing perineural and intravascular invasion. On your left is perineural. It goes along the nerve, and here on the right you can see fungal ball in the blood vessel. This we saw in one of our patients of exenteration near the optic nerve. These are sometimes when you are not sure, because all fibers start looking like mucor and you see many mucor, then you do PAS stain, and the PAS stain gives a beautiful pink colored fungus which can be seen, which you can see it on the screen. And these are also mucor, as well as on your left is Aspergillus. Again, Aspergillus also, and we have started getting both mixed mucor and Aspergillus. In one of the series, there was 8% incidence of secondary bacterial infection, and 72% patients were receiving antibiotics, often with no underlying evidence of infection in COVID. So definitely the treatment has to be done very carefully. And also there are reports from Pakistan, 15.6% mucor they had seen. In Italy, 27.7 fungal infections. So naturally, slowly we are getting data that we are getting various fungal infection where the treatment is because of while treating the COVID. Again, back to my data, see 102 cases, and most of our data is patients from post-COVID patients. We had seen 25 cases in nasal mucosa, 44 in maxillary, and 24 eye enucleation we have seen till now. Out of this 24, 20 patients are hyperglycemic. And recently we had a patient who is 69 years female, and her both eye enucleation came one after another, and it was really very scary to see that the patient's both eye exenteration was done. In our histology, we saw that optic nerve involvement was seen in only 4 cases, and there was perineural and also along with small blood vessels near the nerve, which we could demonstrate in our histology. Periorbital soft tissue involvement of mucor was the most common finding. This was seen in our 20 cases, and other parts like sclera, etc., involvement was not seen in not a single case, and association with sinusitis was 22 cases, and most cases appear like direct spread from the sinuses. This is one of our case recent, which is practically see the perineural, and the fungus is traveling along with the nerve. This is a granulomatous reaction seen. You can see the giant cell along with neutrophils, and such kind of granulomatous reactions are also seen in mucor. This is another perineural. This is mucor inside the blood vessel, and this is the periorbital mucor in the histopathology. Here, I would like to tell one thing, that coupled with potential implications of steroid-induced hyperglycemia, the diabetic COVID-19 patients receiving corticosteroids or other immune suppressant is exceptionally vulnerable to development of mucor. The landmark recovery trial published in June 2020 has served as a license to use steroids in patients with COVID-19. However, the fine print clearly revealed some important message that we seem to have overlooked. Benefit was specifically shown with low dose, short duration dexamethasone in moderate to severe illness. Although higher doses and longer duration may be used in exceptional cases due to compelling reasons, such patients should be evaluated for undiagnosed diabetes, checked for strict glycemic control, and closely monitored for secondary infection. So attitude to the use of steroid, a cavalier attitude, should be discouraged at all cost. But then luckily now, as the COVID is decreasing, I hope mucor will also decrease. And in fact, in my lab itself, I'm seeing less and less mucor for last 3-4 days. So I hope that this mucor problem will be over very soon. Thank you very much.
Thank you so much. Thank you so much, Ravi. I have a question for you.
Yeah.
One is that when you say that this mucor is perineural, which we understand that causes visual loss because of the optic neuritis. Second thing which you said was intraluminar thrombosis.
Yeah.
Now we know that mucor is prothrombotic. But you know, Ravi, I would like to know, where does it enter? How does it enter a central retinal artery? Is it that what you took the samples was the clotting, which the clots showed mucor elements?
Yeah, it did. It did in the clot. Yes, it was.
Did you find the Mucorales inside the nerve?
Only in 4 cases we did see. In 4 cases we did see.
My question is for 2 reasons. One is that the number of exentration being done.
Yeah.
When we can try to save, because sclera is spared, the muscles are involved if it is in contiguity.
Yeah.
But still, you know, bilateral exentration is such a morbid issue that we have people who are expert face surgeons who can do the orbitotomy from the nasal side. So, I mean, just a question. Second thing I wanted to know from you is that you say that it affects the immunity. So a patient who has developed COVID, he becomes immune to COVID. Now, what sort of an immunity he has? Does he have a T cell response, or does it have a B cell response?
See, we don't know about this disease. Basically, for some strange reasons, only a specific group of people are developing these kind of problems. We really don't know that why most of the people are spared of this problem. Even diabetics, like all diabetics don't develop mucor. So what is happening is, frankly speaking, the disease is only 2 years old. We are still, I think, in the learning phase. And that is why I told you that this is an mRNA virus, and probably only over a period of time, with all of us giving our statistical data, we will be in a position to know that, because, you know, sometimes we feel that it is a direct spread. Sometimes it is entering basically it is an angio-invasive virus. So, fungus. So it enters the vessel and it goes, and sometimes it might be going into the central retinal vein also, vessels also. But most of the times what we are getting is either in the nerve or in the perineural, or some thrombus which is showing mucor.
Most of the time we are seeing patients with apical syndromes. We are seeing patients where the invasion is going posterior, it's going to sphenoidal sinus, it's going to pterygopalatine fossa, and you start getting ptosis, we start getting third nerve involvement, diplopia, and vision loss. Even in CRA occlusion, you said, I have seen cases where you do not get classic CRA occlusion. You get pale edema of the optic disc. Yes, vision loss is tremendous. I mean, you have hand movements or recording here. Anyway, so wonderful, Ravi, listening to you. I am sure your data is going to be a big help to all of us. ND, can we go ahead with the next one, please?
Yeah.
Sir, before we go ahead, just a small token of appreciation to Dr. R. Ravi, sir.
Thank you. Thank you.
And also,
It's so nice.
Also to Sauji madam also. We missed it during her talk.
Thank you.
Thank you so much, Sauji madam and Ravi sir, on behalf of BOS and OSN. Thank you.
Thank you.
Wonderful, Viral. Good job.
That's good. That's good. Yeah, Dr. Neha would like to invite the next speaker.
I think next speaker is Dr. Madan Kapre sir, and I think we call upon.
Okay, so now it's.
Yeah.
Oh God. Can I see Madan somewhere there in the screen? Or okay, friends, the most difficult part of today's webinar is to introduce such a personality, such a big giant in the field of ENT, who is none other than a very dear friend and a very, very, coveted figure in medicine, in in ENT in Nagpur. And he's none other than Dr. Madan Kapre. Dr. Madan Kapre did his graduation from our alma mater, JMC Nagpur, and he went to UK for his post-graduation, where he did DLO from London, and I think FRCS from Edinburgh. He is, today at present, he is the director and at Niti Clinic. Now, if I start telling you about his achievements, it will take the rest of the session, but I'll just tell you that he is a versatile personality. His presentations, his, the number of awards, the number of orations, they're all in thousands. He has, if I just look at his biodata, his publications and everything, the most important thing is he's one of the only only ENT surgeon who had given live surgery across 2 continents. So with this small introduction, Madan, with all due apologies to you, because we'd like to listen to you more. Madan is a name in ENT as well as in every walk of medicine. He is, he's involved with anatomy, he's involved with everything. And social, Rotary, he is one of the pioneer figures. So over to Madan for let's understand more on rhino-orbital cerebral mucormycosis. Madan Kapre.
Thank you. Thank you. Thank you, Prashant, for such a lovely and kind words. It's always nice to hear from friends. Sometimes they are, it's flattering and you tend to believe it. Yes, maybe.
It's not. Actually,
anyway, here we go. My talk for the evening is, in just a second, I'll get myself organized. Yeah. Okay. Before we begin, I'll admit very candidly, when this thing started, that is the mucor pandemic, all surgeons were well equipped with all the techniques that we have at disposal, like we had endoscopic surgery, external surgery, all kinds of approaches for the maxillary, frontal, ethmoidal, sphenoidal, and the orbit. But right before it started, we never expected, and we were all lost, and we required a Lord Krishna to guide us. And we are exactly like Arjun, stuck. We knew what to do, but we did not know what and when to do. And before I begin even further, I'm aware and I acknowledge that there would be several stalwarts, seniors, juniors, equals, all alike, who would have probably handled this condition greater in numbers, and I seek their pardon. I represent them very humbly. I do not claim to teach anyone anything through my talk, but I tend to share their experiences during the panel discussion. Now, before I begin, I'll just run through some of the things here, because there are certain things that we want to know is when to operate. So we want to know when the patient is dangerous to me or my staff or the patients along that line, and therefore I want to know the risk assessment as far as patient is concerned. I also want to know what is the potential risk to the patient himself. If he has a bad lung score or a very advanced lung disease, I'm not going to subject him to an anesthesia of an hour and a half and maybe even more sort of a toxic medication thereafter and peril his life. The third is how urgent is it for me to get on with the surgery? Because if the potential is getting into a system where I need to really go in and do it quickly, I want to know that. And the last is, what are the comorbid factors? Diabetes, lung infection, some other cardiac condition, maybe his other status of his a general medical status for that matter, which may preclude me from going in. So when is it safe to operate? This is the first question we want to tell. And the thing we did was, we have a table. And I will not run through these slides very elaborately because you might not be interested in this part, and then straightway come to the surgical approaches. What we did was, we assessed the safety through these parameters, and then we said that unless all these things are conducive, the patient is not safe to operate. And then we said, what is the risk factor associated with the COVID? And these were the kind of a table. And I'm very happy to say that this has been accepted and will be in the Lancet fairly soon. Then we said, what is the risk assessment score? Is it a high risk patient or a low risk patient? And what the severity score? And the tabulated, the one which we skipped was, they give them marks. And if it was a high risk or an intermediate risk or a low risk, we factored that again the severity score, and we had a different kind of a table. The table was that either we have a high risk patient and an intermediate risk patient, and this is what the thing comes. The high risk category patient all belongs to the area of your interest. The patient which had ophthalmoplegia, patient who had proptosis, patient who had other than ocular nerves. For example, many of them showed seventh nerve palsy. They obviously showed the palatal, the sphenoid, but the dangerous sign which I have observed in my own workup is the facial necrosis. If the skin on the face is showing eschar, I think there's a highest degree of risk factor to the patient, and we should get on with the act very fast. The lowest part was when the disease was limited to the turbinals, or maybe inside the nose, and maybe inside the sinus was an intermediate risk. They were not really risky. You could wait for the patient to settle either from his medical condition or on to his anti-diabetic drugs. Now, this is a table which is a little too crowded, but we'll skip that. And we straightway come to the meat of my talk, which is surgical approaches to mucormycosis. And the one was, as we amply known by the chairman, that endoscopic debridement. The less known technique until then was an open debridement, and we had two issues: what approach we take and what extent we take. And the third was, can we combine these together for the best results? And I will run into that. Now, before we run and make a plan, we should have a roadmap. And the roadmap was by way of CT scans. We are very comfortable with CT scans of the paranasal sinuses because we could read them, and any average person into few years of ENT or endoscopic surgery knew exactly to read. But please look at this frontal sinus. I beg of you, all of you, who will say that where is the disease? The disease is not restricting at the frontal recess, but the disease is actually going to the end or the lateralmost part or the furthest part of the frontal sinus. Now, there comes the issue. If the disease has gone that further out, will I get it by an endoscopic approach alone? It's practically impossible to get to that crevice there, and maybe such cases will tell me, maybe here I need to modify and swallow my ego or pride and say, okay, here I will make a compromise and make a combined approach of open versus endoscopy. Look, one more finding here, and that's what exactly the chairperson was very correctly saying, that how is it going in the eye? Can you see something here? I've deliberately put it there. A couple of things to see here. Number one is on this slide, you see the lacrimal sac, and the lacrimal sac is continuous with the shadow in the frontal bone. The frontal recess is continuous, and therefore the disease is already hitting the lamina papyracea, gone into the thinnest part of the lacrimal sac, into the lacrimal sac, and now this will spread contagiously. Now the other slide, which is on the left, will show you that the disease is also breaking through the frontal bone directly. Now MRI. And here we're a little bit foxed because we're not comfortable until this COVID epidemic to read the frontal side, the MRIs. But this opens your eye. Look at this picture, how beautifully it is said that this particular person has got a very interesting mucormycosis. But the one which interests you is this picture. Here you can see there's a complete involvement of the outbreak. But look at it carefully, compare the other image. Although it looks very horrible on the right-hand side, it is not that horrible on the picture which was seen, which we call T1 and T2. And the reason being, you can still see the muscles which are shining brightly, and therefore these muscles are not, although the orbit is involved, these muscles are not involved. That means I can salvage, at least cosmetically, if not functionally, this eye, and will not go tongs and hammer and satisfy my surgical skills by removing that eye. However, we got two different scenarios. One on the left, everything is on the fire. You can see that there are eruptions on the upper part of the gums, which is the disease has come down into the palate and the lower part of the maxilla, and the eye is already non-seeing and ecchymotic. Now, that is very easy proposition. But look at the one which is right, because here we are seeing more things like this now, where somebody has a little sinusitis, but he has COVID, but he has diabetes, and every newspaper, every media channel is screaming out of everything, black fungus, black fungus, black fungus. Now, I'm seeing about a dozen patients like this every day, and not anymore of the one on the lady on the left, thankfully. Now, rationale of endoscopic surgery, as we all knew, was the FES, which was devised for saving every millimeter of mucosa, because we thought mucosa was very precious. And we established the functionality of nose and sinuses and re-established the ventilation and facilitate their drainage. Now, but endoscopic debridement is a complete ball game, different ball game, because here we have no saving of mucosa. We want to remove everything, and therefore this particular procedure is saved for relatively less morbid patient, where the disease is not moving laterally and the disease is not threatening to be inadequately removed if I do not swallow my pride and resort to the external approach. This is an excellent approach for disease restricted to the nasal cavity, centralized disease I call, but I will make a caveat here. And the caveat here that in an expert hand, probably everything is possible. They can remove half the face with endoscope, but not with the younger person who do not share the same experience. Now, open debridement, it's a very quick surgical debridement that you can do, less tolerance status for long-term use of fungal, because we want to be very fast, remove it as much as possible, and particularly if the disease is originating into the dental etiology. This was a little bit missed out, but I would say, I feel a lot of things are happening, not nasally or maybe not entirely through the aerosoling of the nose, but maybe something coming through the disease of the caries teeth as well. And when anterolateral aspect of maxilla is involved, probably the pterygoparietal and fossa is involved. I'll show the pictures. There probably the open approach is best. Open approach is very best when the facial skin is gone and when the infraorbital nerve involvement occurs, because this means that the disease has broken through the confinements of the anterolateral wall of the maxilla and has come into the skin. If somebody has got intense headaches, which probably means that there will be some element of dural attachment, again, an expert can go and remove the disease from the dura also. The eye signs such as ecchymosis, proptosis, ophthalmoplegia, diplopia are another indication to remove it externally. Now, options. What incision do I take? I can take an external fronto-ethmoidal approach, or I can go sublabial degloving approach, or if all things fail, then I can combine orbital exenteration, which is done very infrequently. And of course, the last is diagnostic window. Rationale is excise all the mucosa, but let's go to the pictures. But before the pictures, now what I recommend is best of both worlds. What you do is you take an open approach, facilitate wide debridement, and then do the endoscopic removal of all the hidden corners of the frontal and the sphenoidal sinuses. It also counters the problem of residual. You leave nothing behind because you're seeing it practically with a microscope, which is a magnified vision with the endoscope. And therefore, you can prevent the repeated interventions and exposing this patient for repeated anesthesia or surgical procedure. Now, look at this picture. This is a very standard external approach. The incisions, don't worry, they don't get seen. You can see the lady with the right. She's the same lady on the left. Can you find my incision there? You can hardly see, and this is still not gone home. This is just sutures removed. But that is not a Riles tube. That is the innovation technique which our clinic does, is to irrigate that big cavity by putting it a nasogastric tube, not in the stomach, but into the cavity we have created, and the patient gives a dowsing by herself. And you can see that despite of whatever extent she had, she has still salvaged her eye, and we are doing it nicely, and there is no scar. Now, this is the second approach, which is a combination approach I talked about. You take the lower part of the disease by a sublabial degloving approach. You can see that gamma I was mentioning is on the just last teeth there. And then for the rest of it, you can take a little incision on the eyebrow, which get again hidden very nicely, and clear out all the frontal sinus and towards the lamina papyracea. And nicely, a beautiful word which was used by the chairperson is called as remove the pressure. Decompress the eye. You can wonderfully decompress the eye, take away all the lamina papyracea, you can take away all the floor of the orbit, and the eye is practically without any compression whatsoever. And this is a sublabial approach where you can remove the maxilla entirely. You can look at the gammas. And I may draw attention of Dr. Ravi and Dr. Sanjay also here that please consider that the fungus might be getting in not necessarily through the nose, because they did not have any pathology in the nose seen, but the disease was restricting itself to the floor of the maxillary sinus. This is a window technique I was mentioning, that what you do is when the people come panic, that they think, oh my God, I got a mucor, then you can do a little window, maybe under a local anesthesia as well. Look at inside the sinus. If it looks so clean as it looks here, no need to do anything further. Or at the same time, you can have a little endoscope going through the nose and confirm that your findings are correct. This will avoid a lot of unnecessary surgeries. Now, our technique, this has been popularized, which is called the frontal-first technique. And what we do there is we open up a window on the frontal sinus right in the beginning of the operation and follow that frontal sinus floor right back to the sphenoid, and the whole procedure is finished in less than half an hour. But this is where the disease chase begins. Now, when you start looking at the disease is starting at the pterygopalatine fissure. And from there, it goes into the pterygopalatine fossa, and from there, it goes into the infratemporal fossa. What you need to do is remove the entire back wall of the maxilla and keep chasing it till you find that you are completely excised the disease. And the catchword I use here is you keep on operating wherever the mucor will take you. If it takes you to the infratemporal fossa, so be it. If it takes you to the meninges, so be it. Remove it from the dura, but do a thorough, complete job and leave a very little job to do. Can you appreciate here? I deliberately put the middle fossa side there. Can you see where my finger is sitting? You could see a very nice the maxillary artery. If you see that artery there and you have to ligate the spinopalatine there, you can be always assured that there's a good vascularity. That means no angio invasion. And if there is no angio invasion, your patient has a great prospects of curing himself of the disease. Now, management of eye, I will not take a lot of time here because I know there is someone who's going to talk about this after me, but it all depends upon the extent of orbital invasion, the status of the ophthalmic artery, the availability of the antifungal drug. This is a new factor. No books will mention this, but we are here in Nagpur where we do not have the backup of the antifungal drugs as abundantly as probably the rest of the world, and therefore we have to factor this. Am I able to give this patient a sufficient amount of antifungal drug? And of course, what are my medical and surgical resources? What kind of background I'm working, and what kind of a comorbidity my patients have? But above all, what is the emergency? Let me confess, we are learning. We will not say that the last word is written yet in the book, How to Deal Surgically with the Mucormycosis. least of all is the mode of orbital involvement. We are struggling. Is it through angio-invasion? Is it through direct contact? Is it through the orbit? Is it through the lamina? Is it through the lacrimal bone? Is it through the pterygopalatine fissure? We are also not sure whether debridement and decompression alone should be done. I'm a great proponent of these two techniques, and I'm a little bit not so in favor of orbital exenteration willy-nilly. What is the scope of intraocular injection of amphotericin B? And last of all, we should be enucleating eye, not at a drop of the hat, but your threshold has to be very, very, very high. You have no shame in revisiting, but look at this lady. The skin was gone. The eye was a little bit gone that side. So there is a palsy there. And yet we decided that we will not remove this eye. And we're very richly rewarded for not doing so. So the first question about orbital examination is complete no. If there is good vision, maybe blurring, if the eye is mobile, pain plus minus, and no proptosis, no reason to remove that eye, despite of the fact that there is some evidence of a palsy there. Look at this young girl. Yes and no. 12 years old. Ravi mentioned that into his talk. A Manya girl from Varda. Painful, she had blurring, but eye was mobile. She had a vision. She had minimal proptosis. And you can see from the next picture, she did have inferior rectus palsy. Look at that. But we still managed to give her an eye which was seeing. And of course, there is a little hole there. We have to excite the skin also. We can always do that repair work. I could not get the latest picture. Even that hole is practically a pinhole now, and she doesn't require much. But the point I want to make a mention here is she has her own eye. And maybe clever doctors that you are all on the screen can do her strabismus surgery in future and maybe correct her sort of screen or whatever she's left with, but she will see the world with both eyes and not jumping into one eye exenteration just because she had a rectus palsy. However, here you can hang your boots. See, this lady has got skin gone, the lower lid gone, grossly ecchymotic, blind, painful eye, and maybe here is one indication where I might say, okay, we'll take this eye out, and this is what we did. We removed that skin, we removed the eye, but in this case, you can see my cuts. This is how we take the anterolateral wall of the maxilla. We even go up to the zygoma and take the disease into the lateral part, which is the infratemporal fossa. This is unfortunately, I call a full house, but this does not happen often. I'm very pleased to say this only happened 15 days ago. Beyond 15 days, this has not happened. That means probably we are educating ourselves, or maybe everybody is educating themselves, and hopefully this will be the only picture I have to show you, no more. Lastly, about this is everybody talks, who will be the best person to operate. Is it an ENT surgeon, or is it a facial-maxillary surgeon, or is it an ophthalmic surgeon? Who is to operate? I would say, please don't jump onto it, don't politicize it. If you got good training, if you got good infrastructure, if you have good attitude and aptitude and a kind heart. You see, you need to have a very kind heart and a very, very sympathetic thing about the eye. Don't be jumpy. I don't like this particular thing, saying, oh, we removed 66 eyes, or we removed, and I will say, I should hang my head in shame if I have to admit how many eyes I have removed. And thankfully, I haven't actually removed. And the number of the eyes which have been removed are probably in the first part, where we were not aware of the techniques of debridement, the techniques of how to save the eye, and even techniques of understanding that a pink-looking muscle is a surviving muscle, and that muscle need not be removed. You can take away all the inherited fat, you can take away, but leave the eye, if not a functional eye, but at least a cosmetically looking eye, so the patient is not sort of going into all the phases of having a big patch on his face, like a dead skin on there, rather than having an eye which looks practically near normal. And I would say again, no making a politicizing of who operates mucormycosis. Anybody who is good, anybody who has a good aptitude and aptitude and a good infrastructure, please go ahead, because you are alone. You need a good pathologist, a microbiologist, an infection specialist, an intensive therapist, a good eye surgeon, and a good later on a facial maxillary and a reconstructive surgeon. If you got that all infrastructure in place, please go ahead and do the lot of mucor surgery and give us a feedback, because at the end of this pandemic or endemic of mucor, let us show the world, because the world doesn't know about this. We have a great onus upon us to formulate guidelines, and I'm very happy that we have formulated guidelines, and our guidelines may probably appear in Lancet within the next issue. I've been assured by the people there. Hopefully those guidelines will be out. Thank you very, very much for your patient hearing, and I might a little bit exceeded my time, but I'm sorry. I just tried to be as concise as I could. Thank you, Prashant, and thank you, everybody.
Thank you so much. You actually were such a balanced view you gave it to us, and I'm with you in that assessment that exenteration should be last resort. When you have nothing else but exenteration to save the patient's life, then only you should think about it. Because now it is the ENT has evolved so much with your Dunker's procedure, with your ability to do our orbitotomy through the nose. I mean, I saw in one of the webinar, and if time permits, I'll just give a 3-minute clip on that, where a ENT surgeon could go lateral to the optic nerve. He debrided the optic nerve. He went behind and up to the sphenoid and everything and removed it through endoscope. So probably what you gave is such a balanced approach. And I'm sure now the next speaker is going to tell us more about what are they doing at an institution like LV Prasad. Andy, can you call the next speaker, please?
Yeah, now I would like to invite.
That would be a great job.
Yeah, sir.
Dr.
You proceed further. A small token of appreciation to Dr. Madan Kapre, sir, on behalf of our VOS and OSN family. And sir, because it's a webinar, we can't present it physically to you, so a soft copy is already sent to you, sir. Thank you, sir. Thank you so much.
Thank you.
Sir, please.
Yeah, I would like to invite Dr. Milind. And before that, I request Dr. Shivani to introduce Dr. Milind Naik from LV Prasad Institute.
Thank you so much, sir. Good evening. Thank you, Team VOS, Team OSN, for giving me this opportunity to introduce my very own mentor, Dr. Milind Naik. He's done his MD from Christian Medical College, Vellore. He did his fellowship in ophthalmic and facial plastic surgery from UCLA, Los Angeles in 2006-2007. His areas of interest are aesthetic and facial plastic surgery, thyroid eye disease, and minimally invasive ophthalmic plastic surgery. He's a recipient of Senior Achievement Award, American Academy of Ophthalmology in the year 2015. He was a vice president of the Asia Pacific Society of Ophthalmic Plastic and Reconstructive Surgery 2010-12. Currently, he's the consultant at Department of Ophthalmic Plastic Surgery, LV Prasad Eye Institute, Hyderabad, and an adjunct associate professor at University of Rochester, New York. He has almost around 250 plus peer-reviewed publications, as well as over 300 national and international presentations. And he's on the editorial board of Journal of Cranio-Maxillofacial Trauma and Reconstruction, Korean Journal of Ophthalmology, and Journal of Cutaneous and Aesthetic Surgery. A very warm welcome to you, Dr. Milind Naik, and I request you to begin with your presentation.
Thank you very much, Shivani, for that kind introduction. Am I audible?
Yes, sir.
Yes.
First of all, a big thank you to the Vidarbha Ophthalmic Society and the Nagpur Ophthalmological Society. It's always a pleasure to come back to VOS. My association with VOS has been for last several years, and there is so much of talent in VOS, not only in ophthalmology, but beyond that. And it's always humbling to meet the friends again. So my job today is to talk about mucormycosis ophthalmic considerations. And as has been mentioned by Dr. Kapre earlier, that this is something which one specialty cannot do and achieve. And it is important to join hands with other specialists. So although I am making this presentation, whom I represent is a big group of the mucormycosis task force, which is working back home here at LV Prasad across all our 4 campuses. And this consists of ophthalmologists, microbiologists, pathologists, and even maxillofacial and ENT surgeons outside our institute. So it's a combined knowledge base of all of these that I shall be presenting. A quick touch up upon Why COVID and mucor? I'm guessing all of you must be aware of it by now. The uncontrolled diabetes, either pre-existing or the one induced by the virus, then indiscriminate use of steroids, sometimes essential. And I would also add indiscriminate use of antibiotics, which are often prescribed in this condition. Breathing devices and their safety is controversial, but still could be a contributing factor. And all these things have really caused the surge of mucor at this point of time. And there's increasing literature joining the factors between these two. But what I'll touch upon is the clinical spectrum as we see it as ophthalmologists. How do you diagnose it in a simplified and quick manner? And an overview to the treatment without going into much details. Talking about clinical features, when a patient comes to you who is post-COVID and probably a diabetic, these are the signs and symptoms that they might describe to you. Periocular pain and swelling anywhere on the face, headache, blurring of vision, a sudden droop in the eyelid, and nasal discharge of heat. Sometimes this may not be very apparent to them because they're primarily worried about the blurring of vision, but this is something which we should ask them. As far as the clinical signs go, sudden onset ptosis, proptosis, which can often be surprisingly minimal because there isn't a mass behind the eye. Ophthalmoplegia is a very important sign. You could fit it either into third, sixth, fourth, or a combination of these nerves, along with fifth nerve sensation reduction. Facial discoloration, as you see in this picture, is a poor prognosticator. Central retinal artery occlusion, as you evaluate the fundus in a majority of cases, but in some cases you could have a more proximal block and you may not see a cherry red spot. Go beyond the eye and also look at the palate. If it is discolored or if it's showing a black eschar, then that is an involvement of the floor of the maxilla. Nasal discharge, nasal bleed, clots, or even a direct eschar visualization is very pathognomonic. Many of you would be called by your ENT colleagues or maybe the nearby multi-speciality hospitals to see a suspected patient, and you might wonder what you really need to tell them. So you really need to assess the vision. It may not be exact on a Snellens, but there are several apps on the phones available which can be used at this point of time. Fundus evaluation to know whether there is a central retinal artery occlusion. This information is important for the ENT surgeon or the other specialist who might be managing this patient. Also check for motility and note the extent of involvement of the movement restriction. We have designed a scoring system which is yet to be validated based on the symptoms that the patient presents and the signs that you pick up. We have designed which patients need further imaging and nasal endoscopy and which are the cases where you could possibly observe, but to be on the safer side, it's better to investigate. So what do you do next? You have someone with these signs and symptoms. You obviously need imaging as your next step. Between MR and CT, MRI with contrast is definitely preferred over CT scan because it can pick up more findings within the sinus, within the nasal cavity, as well as the orbit. But contrast is not always easy. Many of these patients have systemic comorbidities. If the renal parameters are not stable, then contrast can be a challenge. So you could accept a CT with contrast or even sometimes CT, plain CT as a compromise rather than not doing anything at all. And what do you look for in the orbit? We already have had extensive discussion about the sinus findings. But in the orbit, it could either be completely not involved, or you could just notice an extraocular muscle enlargement and nothing else in the orbit. Or you could see a focal involvement as you see in the inferomedial orbit in this third image. A more diffuse involvement or apical involvement can also be seen. So if you see this triad of ophthalmoplegia, sinusitis, which is very minimal sometimes, and central retinal artery occlusion, unless proved otherwise, this is mucor. So what is needed next is a diagnostic endoscopy, and this is where your ENT surgeon would help you. If this patient is presenting to an ophthalmologist, you should quickly involve them. And if you see a black or grayish eschar as is seen in this, it is very pathognomonic, and this itself, in the given scenario of post-COVID diabetic patient with all the other signs, you could practically start them on antifungals and then go for your microbiology and the pathology evaluation. We had excellent talks on these topics, so I won't go into the details, but microbiology and pathology would only confirm your diagnosis if you have to do anything more destructive, like exenteration. Otherwise, your clinico-radiological diagnosis is enough to start the patient on medications. This disease progresses very rapidly, so you have to act fast. And this is a sort of overview of what you would do for management. Based on your clinical suspicion, you could actually start the patient on amphotericin. And once the doses have gone in, you could confirm the diagnosis by nasal swab or histopathology. We still do not know whether a nasal swab is really helpful. But we're trying to acquire samples in patients nevertheless to know its utility, because even if 1 in 10 nasal swabs in the absence of an ENT surgeon access can detect mucor, it could be life-saving. Once you've confirmed it, you have broadly 2 ways of managing it: exenteration and non-exenteration or salvage options. And we would come to these one by one. So if you look at the literature pre-COVID about mucormycosis, it's primarily divided into exenterations and non-exenteration. And the medical treatment consists of amphotericin, posaconazole, and all the other second and third alternatives that are available. Personally, we always involve an internist for this management. In fact, it's not done in our standalone eye hospital, so I won't go into these details. But I'll talk a little bit about retrobulbar amphotericin, which is applicable for patients who have visual potential. So it's an off-label application. The dose recommended is 3.5 milligrams per ml of ampho, which is combined with an equal amount of lidocaine for anesthesia in a 1:1 ratio. What's the concern? The concern is neurotoxicity as well as compartment syndrome due to the inflammation as a side effect. There is very limited data. In fact, there are only 4 case reports of this application. So we really do not know as to how many injections are needed, what you should assess after these injections, and so forth. We are just collecting data. And as Kapari rightly mentioned, we are learning what's happening here. So here is a video I'm going to run about intraorbital ampho. It has its own audio, and just let me know if the audio isn't running.
Hello everyone. This video demonstrates the intraorbital amphotericin injection for orbital mucormycosis. We will look at the reconstitution and the procedure. Here is a patient who is a 65-year-old male who has a visual potential in the right eye, and sinus debridement has already been done. If you look at his scans, you can see that the inferomedial part of the orbit is involved, and that is what would receive the amphotericin injection. So we take the amphotericin deoxycholate 50 milligram lyophilized powder vial in a 20 cc syringe. First, you aspirate sterile water for injection. Since the vial is only 10 cc, you can only aspirate 10 cc of sterile injection to begin with. Your goal would be to add 14 cc's in all. So initially add the 10 cc into the vial, the powder gets dissolved. Then you aspirate the entire amphotericin 10 cc's into the syringe. To that, add 4 more cc's of sterile water. This gives you 50 milligrams in 14 ml, which makes it 3.5 milligrams per ml. So here is your 14 cc's ready. You can now place it back into the vial. The vial can at the most accommodate 12 cc's, which is ready for future injections, and you can store it with a date. The remaining 2 cc's, you can draw your first injection on the day of reconstitution. So 1 cc of ampho, 3.5 milligrams, and then we also take 1 cc of xylocaine 2% without adrenaline. So these two are what you need for your injection procedure. The process can be done at the bedside with sterile aseptic precautions. We are going transcutaneous into the inferomedial orbit. First time injecting the xylocaine, following which you give a 1 minute gap time, and then you inject the amphotericin in the same manner. A slow injection into the intended area based on your evaluation of the imaging. Thank you very much. Hello, everyone.
So coming to the final topic, that is exenteration. Again, there is no consensus on which cases should be exenterated. What happens, whether the survival improves if you exenterate early versus late, there is no data. And even if you look at mucormycosis papers before COVID, there has been no consensus. There are only risk factors that have been identified, and so basically, my personal take here is if you have a non-seeing eye with a progressive disease, panophthalmitis, confirmed CRAO, or your discoloration, here you might want to do an exenteration to reduce the fungal load. Whereas if you have a patient with partial vision or even no vision, but a fairly stable looking eye, even if it has multiple nerve palsies, but if it is responding to the IV medications, then I would avoid exenteration in these cases. And if at all it is possible, do an eyelid sparing exenteration so you can close the skin over the socket. So the healing is better, even their social presentation is early on acceptable. Poor prognosticators here would be palatal involvement, facial necrosis, age above 46, and frontal sinus involvement, but this is coming from a pre-COVID paper. So just to summarize, there is a high degree of clinical suspicion that is needed. And on the basis of clinico-radiological triad diagnosis, you could start the patient on antifungals. You would need biopsy or microconfirmation, but that need not wait. Early debridement and antifungals and retrovalvular ampho. In selected cases, we have very limited data on this aspect. At our hospital, we do have mucormycosis hotline number where patients can approach, discuss their problems, and find information about where to connect. And once again, a big thank you to all the team working back home here at the hospital. Thank you very much.
Excellent, excellent. Milind, your lucid talk is going to really give us give us a lot of information. One report about the intraorbital amphotericin. You don't need a liposomal, no? You need an collator.
If you can have liposomal, that's an added advantage.
That's the problem, because since we are not bothered about the nephrotoxicity and it's going to be the local effect, probably we can use deoxylate also.
Both can be used.
Yeah, and
but between the two, definitely liposomal would be a choice.
One case report which I had read about was that it was given in 2 days interval, 2 injections, and the vision improved from 20/200 to 20/40. So that is one report. And probably if you're waiting for any major surgery, giving an intraorbital makes sense. And just if you can avoid exfiltration, as you rightly said, it's going to be a great thing. Thank you so much, and keep doing good work as you always do. Andy, the next topic is by Nitin.
Yeah. Thank you, Milind, very much for enlightening us as far as retrobulbar injection is concerned. That's good, and please be there for very good panel discussion after this talk from. Let's have talk from Dr. Nitin. Yeah, Dr. Nitin is here.
Andy sir, before we proceed further, a small token of appreciation to Dr. Milind Naik sir on behalf of OSN.
Oh yeah, sure.
Sir, thank you so much, sir. Yeah.
Thank you.
Yes, sir. Dr. Rahul.
Yes, sir. This is my immense pleasure and privilege to introduce Dr. Nitin here. He is an eminent infectious disease specialist from the city, and he is working with Alexis Hospital. Formerly, he was associated with Wockhardt Hospitals, Nagpur, where he has spearheaded infectious control and antibiotic stewardship program of all the hospitals of Wockhardt Group in the country. Dr. Shinde has many national and international publications to his credit. He has written multiple review articles and also peer-reviewed papers in the scientific journals. He has contributed a chapter in the popular API textbook in the 14th and the 15th edition. He is also a contributor and reviewer in drafting the National Infection Control Guidelines published by the Ministry of Health and Family Welfare. A very warm welcome to you, Dr. Nitin Shinde. Over to you, please.
Thank you, sir. Thank you to VOS. And this is a very splendid discussion. And I'm also learning a lot of things about mucormycosis. And I will quickly go through the post-surgical management of mucormycosis through my slides. And I think this is very, very important because we have seen people struggling, patients and as well as clinicians struggling after they finish off the surgery, and so they do not really know how to go about that, and patients keep asking a lot of questions about their next course of action. 1 second, my slides are not moving.
You start your screen sharing, Nitin sir?
Yeah, this is 1 minute.
Yeah.
Can you see it now, sir? Yeah. All right.
No. Yes, now we can see. Yes, go ahead. Start your slideshow.
All right. So I think I will not go into all this discussion. I think we have thought about this, that this is a misnomer. So I'll quickly go to the couple of important topics which is important in the management of mucormycosis. So a lot of people ask me, should we start on patients on prophylaxis who are likely to develop mucormycosis? So, but currently there's no role of antifungal prophylaxis in all these high risk cases because of two things. We already have a short supply of all the antifungal medicines. And if you really look into the incidence of mucormycosis, yes, it is very high, but we do not know the denominator. So if we really see the incidence of mucormycosis and if we compare it to the hem-onc population, it is still low. So currently it is not been recommended. So therapy is basically, we start with empirical therapy and we'll try to rationalize based on what organism we are dealing, what type of mold we are dealing with, it's Aspergillus or any other novel fungi. We have been seeing a lot of novel fungi, and Sanjay Sauji ma'am has done excellent work on this. And we have been occasionally seeing anaerobic bacteria and aerobic bacteria also here. So either there is no fungus, clinically they look like fungus, but there's no fungus, and or there's a symbiotic infections of bacteria as well as molds. So empirical therapy, the drug of choice, everybody knows, is the amphotericin B, and there is no RCT because of the mucor is considered as a rare disease pre-COVID era, and so there's really no RCTs which has established the superiority of treatment over one another. And there are different formulations of amphotericin B which has added confusion overall. And one important point here that we have seen a lot of COVID patients going home with a tablet voriconazole as a discharge and as a prophylaxis. But voriconazole does not have any activity against mold, against mucor. And so using empirical voriconazole to a lot of patients post-COVID is actually will help to increase the incidence of mucor in these kind of patients. So voriconazole should be not be used in as a empirical prophylaxis for patients. So these are different preparations of amphotericin B, and will eternally get confused between these preparations. The most popular is the deoxycholate preparation as liposomal preparation. The two other preparation, ABLC and ABCD, colloidal dispersion and lipid emulsion of amphotericin B, as are pharmacokinetically not so superior to deoxycholate and liposomal. So that's the reason they are not being very commonly used. So the superior formulation is liposomal amphotericin B, and we can see that it has a very high AUC compared to the deoxycholate amphotericin B, and very low nephrotoxicity, and the risk of infusion reactions is very, very low. And in fact, we are managing a lot of patients who have been given amphotericin B at home. So it can be managed because of less infusion reactions. And I think all of us, we know that the nephrotoxicity potential of different amphotericin B and the liposomal composition, it scores over all other formulations. So normally there is a habit of doing a dose escalation in whenever you are using amphotericin B, for example, cryptococcal meningitis. So we start with a lower dose and try to escalate. But when we are treating empirically for mucor and probably rhinocerebral mucor, we do not do a dose escalation. So we directly start with a dose which is like 5 milligram per kg body weight, or 1 milligram per kg body weight for deoxycholate amphotericin B. A lot of other drugs like fluconazole, voriconazole, echinocandins, caspo, anadolomycophamine, or flucytosins has no activity against mucormycosis. So, those drugs cannot be really used even as an adjuvant therapy in mucormycosis. And generally, combination of antifungal therapy is not recommended unless and until you are seeing a breakthrough therapy or breakthrough after debridement. And for all the reasons, the liposomal amphotericin B has been superior in safety and efficacy based on many studies. There's no RCT, there's a small study which is a post-transplant patient, a solid organ transplant patient, where the mortality is less in the patients who have liposomal amphotericin B. This is an excellent resource for the treatment of amphotericin B. These guidelines will be recently published on May 2021 by the Fungal Infection Study Forum of India. And I think this single page slide is very, very important. So the treatment of COVID-associated pneumonia, so liposomal amphotericin B or lipid amphotericin B can be used, and the doses has been mentioned. And if you do not have these two drugs available, then you can use polyans like isavuconazole or posaconazole. Itraconazole has never been a drug of choice for treating mucormycosis, but considering the shortage of posaconazole, isavuconazole, and amphotericin B deoxycholate, after discussion with a lot of mycologists all over the world, the committee has recommended use of itraconazole 200 milligram TDS, which is very high dose, much higher than normally used in demoeticious fungi. So this is a high dose which is being which can be used in mucormycosis if you do not have the stock of all first line medicines. So when you have a stable disease, you can shift the patients to oral azoles. If you have a progressive disease, probably you have to escalate the dose of amphotericin B, or you have to change the class of the drug. If you're using an azole, change to amphotericin B. If you're using amphotericin B, please change to the azole. And in case of toxicity also, we can change the group of drug. So the main arsenal of treating mucormycosis or fungal sandwich disease, for that matter, is amphotericin B, isavuconazole, and posaconazole. So these are the alternative agents, and there are a lot of pharmacokinetic issues with posaconazole. More issues with syrup, because pharmacokinetics is very, very erratic, and you have to stop taking pantoprazole. You have to take it with food. You cannot take it in empty stomach. So there are a lot of instruction we need to give to patients. So tablets are pretty better, less issues, pharmacokinetic issue with posaconazole tablets. Isavuconazole is a newer antifungal agent, and it has been approved for use of use in mucormycosis as well as aspergillosis, and it is less pharmacokinetic issues, is water soluble, and it achieves a very nice drug level within a short period of time. So these two drugs are basically being used not as a frontline treatment, but as first line treatment. It can be used as salvage therapy or as adjunctive therapy. And there is always recommended to do a therapeutic drug monitoring for posaconazole. It achieves drug concentration after 6 days of treatment of therapy. And it should never be used as a first-time therapy unless there is a compelling reason. TDM is not required for isavuconazole. Is a fantastic water-soluble azole, the third generation azole, and there's no data for combination treatment. So there's one caveat with isavuconazole is that a lot of mucor are sensitive, but there are a lot of other species which may not be sensitive. So it's a susceptible test may be required, but the problem is that they do not happen in many labs. So you really have to send your samples to a tertiary reference lab like CMC Vellore or PGH Chandigarh to find out susceptibility. So, and there are other therapies for other fungi like Aspergillus and other fungi. Voriconazole you can use when you're very, very sure that there's no mucormycosis sitting on the lesion. So you can use 6 milligram per kg body weight loading dose and 4 milligram per kg body weight twice a day. And you can also have, I have seen patients who have no fungi, purely gram-negative bacteria sitting in the palate, causing palatal perforation, sitting in the sinus, causing sinusoidal the skin discoloration and cavities in the sinuses. So I think we should really look into that, and we should also see whether there's a gram-positive bacteria sitting, there's an MRSA, there's an MSSA, and we have to really rationalize your antimicrobials along with your antifungals you're treating empirically. This is one of the most controversial part of this treatment because most of the questions, what's the duration of therapy? So duration of therapy, there's no clear-cut duration of therapy in each site. It depends on which organ is involved, what is the severity of infection, what was the adequacy of debridement. Sometimes the debridement may not be done for some other reasons. Sometimes it is not adequate. And there are a lot of other factors also. For example, co-infection, the patient status, the control of hyperglycemia, other comorbid factors in the patient. So all these things are really, really important to decide on the duration of therapy. So the minimum duration of therapy for all these cases is from 3 to 6 weeks is the minimum duration of therapy. And you can cut down this duration of therapy if patient is really well and there's a complete clinical and radiological resolution, and there's a resolution of risk factor. For example, hyperglycemia is achieved, immunosuppression has been reversed. So these are the endpoints where you can really cut down the duration of therapy, and you can really increase the duration of therapy if these factors are not achieved. So minimum 3 weeks and up to 6 weeks you can give the antifungals for these patients. These have been prescribed by the ICMID guidelines in 2013. So I end this, and I think we can have more discussion and answer those questions related to the post-surgical management of mucormycosis.
Nitin, it was an excellent overview of all the various therapies available to us. And I'm sure we are looking forward to the discussion in which we have some questions for you. Andy,
yes,
who is the next one?
Yes, sir. Before
this
is a discussion, he was the last speaker, Dr. Nitin Shinde. We appreciate your presence in this excellent talk on behalf of the. So over to the chairpersons and panelists and the faculty.
Viral, what time, how much time do we have?
Sir, we have plenty of time, sir.
Plenty of time?
Yes,
so if you permit me,
yes, sir.
I would like to show one FES orbitotomy where the endoscopic surgery orbitotomy is done. I have presented this in the BOA.
Sir, you can do it quickly, sir. No problem.
We can do it?
Yes, sir. Please.
Okay, okay. So let me go to my screen. You know, actually, the consensus is let's avoid as much as exenteration we can avoid. Let me see, where do I have that? Do I have to exit from this to go into my slides?
6 o'clock share screen. 6 o'clock share screen.
No, 6 o'clock is share screen, but I have not put that my presentation. Let me see if I can get that.
In a pen drive. Till then, we can start the discussion rolling.
Okay, you can start the discussion. I'll Andy and the rest of the panel. You can start. I can find out how to go there.
So now let us open the session for panel discussion, and we have the eminent panelist, Dr. Prashant Bhawankode, Dr. Gopal, Dr. Rajesh Joshi, Dr.
Hello, sir. Andy, sir.
Ashish Kambre, Ashish Sakpal, and and Dr. Milind Changole. Milind Changole is the oculoplastic surgeon from Nagpur. And now let us start the questions, whatever people want to ask.
A small request, sir. All the participants should put their videos on so we can see them on the live also. All those who have joined, please keep your videos on. Yeah, sir. There is a question on the from the delegates on our webinar panel. In fact, it is from Dr. Karandikar sir itself. Should biopsy be done or scraping be done? I think Kapre sir or Milind Naik sir would like to take the question.
Can I take it?
Yes, sir. Please, sir.
Frankly, if you can take a specimen while you are doing an endoscopic assessment of the disease, and as Dr. Ravi amply elaborated, and send the specimen without diluting it, send the specimen as it is to him, and he can probably give you back the answer within 10-15 minutes. This is one way I handle it. Biopsy, if you come next day, is a little bit too late to take action. The other thing what you can do even intraoperatively when you are doubting that whether this lesion is mucor and therefore do I need to proceed with more surgery, same technique can be employed. So I would say biopsy, but the staining technique should be left to the pathologist.
Sir, can I ask you one question related to orbital approach? So when do you decide to go for orbit on the basis of CT scan or on the basis of MRI?
MRI, a combination of both. You see now, in fact, the radiologists have become very kind to us and they are giving us a package where they would do a CT scan to get the bony landmarks and then they will do the MRI of the orbit and the relevant part of the brains to let us know the extent the eye is involved.
Dr. Kapre, you know, when you're doing this endoscopic surgery, basically you want to remove all the dead tissue, debridement.
Yeah.
The only way you can come to know before surgery that which is the dead tissue line or which is the, is the only contrast studies with MRI. So MRI has to be done if you're going to go for surgery.
Yeah.
Am I right or wrong?
Absolutely correct.
Correct. But so probably, because these mucus spread so fast that probably sometimes delaying doing CT and then, planning the surgery and then going for MRI contrast studies. I agree, contrast studies have to be done with the T2 weighted image with fat subtraction technology, whereby you can actually demarcate that this is the dead tissue and this is the live tissue.
Absolutely. But the final call you will take when you actually see the tissue with your eyes.
Actually, if you permit me, you're right. If you permit me, can I show that video of FES orbitotomy, whereby which an endoscopic surgeon is going behind and removing all the optic nerve coverings and everything. It's just a 3 to 4 minutes video. And then we can come back to this question, whether what is to be done. I'll just share my screen. Now this is you can see the optic nerve. Can you see the optic nerve now? Yes, it has been debrided. And it is on the lateral side of the optic nerve, you can see the mucor tissue. And the surgeon, he is using his debridement instrument and he's trying to remove all that. He has entered the orbit from the medial wall and you can see how much tissue has been involved. This is a 37 years old female bilateral mucor, loss of vision, both eyes. So obviously bilateral exentration was not, advised. And the surgeon was really capable of really removing. You can see now all the fat tissue which was involved has been gobbled away. And once you do all that, probably you leave behind a vital tissue where the drugs will reach. And they use this amphotericin B jelly to apply locally. And this is followed up by doing a repeat endoscopies every second day to see if you have left behind something, because that's another thing, that after doing such an extensive surgery, you may have left behind some part of mucor which will be increasing. So this is just to show that from the nose, you can actually enter the orbit, you can actually remove, and at the end of this surgery, you'll find that everything, whatever black thing was there, was totally eaten away by this a wonderful cutter. You know, we use it vitrectomy, these kind of cutters, and these debriders, which are really, really wonderful, which can, you know, you can actually pull the optic. Now you can see the eyeball also, you can see the sclera, and now he is working on the lateral wall and the sphenoid fossa, or the sphenoid sinus, greater sphenoidal bone and all. And now you can see that everything has been removed. Practically all the black tissue, all that, and probably this is done because the person underwent MRI contrast and he could find out the delineation of vascular and a non-vascular tissue. That's all. Thank you so much. I mean, now we can go ahead with the discussion, please.
Thank you, sir. Thank you so much for that excellent video. It's an advantage to have a ENT surgeon in the family during this time, sir.
Can you freeze the picture for a while, Prashant?
Yes, yeah, it is going on.
No, can you see, look at this?
Freeze it, please. Yeah.
Yeah. Look at this picture. You can see that all the tissues on the right-hand side of your frame are looking little pink and bleeding.
Yes,
from our that's a very important sign.
You can see
that tissue which is showing some blood extravasating from it can be left behind. True. And because that's a live tissue and that is probably not angio invaded. Because if it was angio invaded, it will cause necrosis or ischemic necrosis of the distal tissue. And you can see the clear-cut difference between the tissue above the optic nerve and tissue sort of I would imagine this is the left eye. So the tissue which is to your right and above are two different color tissue. It's very important to understand that color difference. So you can take away that where the debrider, where look at that now. As
bleeding has started. Yeah.
To the live tissue, it starts showing some blood. So we love bleeding here. All other places, surgeons don't like blood. This particular surgery, we enjoy bleeding.
Thank you. That's what I wanted to show, that exentration is not the only option. We can definitely go in and do this. Thank you. I'll stop this.
Viral, can I come in?
Yes, sir. Yes, sir. Please, sir. Gopal, sir.
Just to set the ball rolling. I mean, first of all, let me compliment all the speakers, Dr. Sandhya, Dr. Ravi, Dr. Kapre, sir, Dr. Milind, and Nitin, for the wonderful presentation. There is one question which I would expect Dr. Kapre and Dr. Milind to answer. Which case and when is the right time for exentration? One. Second part to the question, when Dr. Milind answers this question, most of us are general ophthalmologists. As the patient puts the chin on the chin rest, he normally takes the mask out. And we have specifically instructed one of the sisters that the patient, the moment he sits, ask him to put the mask up. But as far as the mucor is concerned, is it advisable, Dr. Milind Nayak, to at least make the patient unmask and look for the palate or loosening of teeth and other stuff which can clinch the diagnosis even before the orbital signs appear? Just Dr. Madan Kapre can answer the first question and Dr. Milind Nayak for both the questions.
So who goes
Dr.
first?
Madan Kapre directly sees the patient. He doesn't have a slit lamp to.
Concentration, which case and when?
Oh, I was going to say, you see, if I had to elaborate on the sort of a first question, where would you definitely say that this eye needs to come out? Probably, if you look at my analyzing things, more we are going conservative, more and more we are thinking that can I get away by debridement? And it is practically any eye which can be salvaged during surgery, which looks, although you might have taken a consent for debridement, I mean for enucleation, you may still not do it at the end of the day if you can find some red tissue, some vascularized tissue. So in the beginning, probably people thought a blind eye or a congested eye or a ophthalmoplegic eye or a paralyzed one of the muscles was an indication to go ahead. But I think those indications are shrinking, and now probably a very grossly ecchymotic eye, the lids are necrosed or ischaric, and when you open up, nothing bleeds, everything is all black pus and necrotic mass, maybe that. But you will revise your decision even at the last minute and may decide maybe I not. As regard to your second question, I would like to say, if you look at my presentation, I had categorically said, when am I safe from my patient to go ahead and examine and do the surgery, because you're operating into the area which is full of virus. And from that point of view, we are very lucky that very small number, in fact, 2 number in my series of over 60 patients, they came within 7 days of their COVID infection. That means they were potentially still infective. Most of the time, these people are coming beyond 2 weeks or maybe around 1 month's time. So theoretically and probably practically, you are safe to examining them the way you wish to examine them. And we do nasal endoscopies to assess the disease. You see, it's like this. Some people will insist on doing RT-PCR. Some people insist on doing antibodies. How much you can rely upon them, I don't know. If he's 14, 15 days beyond COVID, and I'm very confident that he has been pulled out of it, I'm happy to examine the patient and undertake him for surgery as well.
Yeah, Dr. Shinde. Dr. Shinde wants to put in a comment.
Yeah, I would just want to add here that the infectious duration of COVID-19 starts from 2 days before actually the symptoms start. So they are infectious from day 1 of symptoms to day 10 of illness. So beyond that, they are not infectious, and this has been proved by many studies, and there's been a lot of meta-analysis that has been published, because this is the first thing the researchers had looked into. So they are not infectious beyond 10 days of illness.
Nitin, can you tell me why RT-PCR test comes positive? The dead virus also gives a positive result?
No, I think the repeat RT-PCR test is not at all required. I mean, why it has been being done? It just picks up. It is not required, and the ICMR has come up with the recommendation after 1 year of epidemic. So it should not be done. There's no reason to do an RT-PCR unless and until you are treating cancer patients.
Now, since
you're treating a very highly immunosuppressed.
Since we
patient. Are cancer patients can really have a.
What is this?
Yes,
CT value of 24, and what is the?
They are very no. They are very unreliable. And there has been a lot of papers which says the CT value and the disease severity has no correlation. CT value and infectivity has very crude correlation. I mean, you cannot really say that somebody who has a CT value of 32 is not infectious without looking at the clinical course. So these things are very crude, and we cannot have a really very high on those things. So infectiousness is time based and not test based. So if somebody has finished their 10 days of symptom onset, probably they're not infectious. Only cancer patients, they have on chemotherapy, they have GI cancers, they're on chemotherapy, they're leukemias, they're lymphomias. They can transmit the disease for a longer period of time. And the patients who are severely sick, ARDS and all that, who's gone into cytokine storm. So some of them can transmit the virus for a longer time. But majority of patients, they are not infectious beyond 10 days of duration. So what Kapre sir has said, 2 weeks is a really good time window. Beyond 2 weeks, they are really not infections. So I don't think we should worry.
So, Dr. Nitin, I want to ask one again question.
Yes, sir.
Yeah. How do you convince government who want RT-PCR negative test once the patient who has come from abroad to India and he has been tested positive for RT-PCR, he has waited for 20 days, but still RT-PCR is positive?
This is political question.
Yeah,
so.
that doesn't make any sense, because there are a lot of papers which has been saying even without travel, the UK has put a travel ban on India for a long time ago. In spite of that, they had a new 617 floating there in the UK. So travel has actually no correlation with spreading of variant and strain. So testing before travel, testing after travel doesn't make any sense.
Saurav, it's something like this, that people initially said ivermectin, then they said remdesivir, then they said, see, all these recommendations are coming anecdotally. There is no government body, no ICMR, nothing which really gives you a scientific data to substantiate what you should be giving to the patient. And I think, Nitin, you'll agree with me that lots of treatment, including favipiravir, everything has been done empirically. And probably, the zinc, I mean, Mucor, a lot of people are saying the amount of zinc and vitamin C we are consuming is phenomenal. So a high time, I mean, yesterday, I don't know whether the news was right or wrong, but I was getting a news that Devi Shetty may become the health minister of India. So probably, you need people who really, look at science in a very, very analytical, very, very research based, and then suggest, because once you say remdesivir goes out of the market. So probably I think the government has to look at it. That 2 years we are into this, 1.5 years, let's say, we are into this pandemic and we do not have standard of care. Dr. Kapre, would you agree that there should be I really like the charts you made. I mean, can that chart be made, and recommended by the government? That this is the chart, like for exentration. I would definitely like a clear-cut guidelines for exentration. I mean, I'm seeing a patient with a completely white eye, exenterated, and the eyeball is there, lying on a petri dish. It is so painful and so pathetic. But yes, we have to be scientific. We have to give the best to the patient. And I think open to all that we have to take advices from everybody, but we have to follow our clinical judgment in our clinical course. Dr. Kapre, what do you think about it?
Yes, you see, this is a place where when we conduct the first webinar on Mucor ENT wise, there were a lot of people from UK on the show, a lot of people from Australia and also from America, and they actually requested themselves that they have never seen so much Mucor in their whole life. They do not know what to do with it. And they actually requested, why don't you form a guideline to do various things? For example, which patient will you operate? When will you operate? What surgery will you do? What kind of investigations would you recommend? And the charts which I showed you are to be submitted to the Lancet people. And if they agree with all that, it may actually become a standard of care or kind of a guideline. Because you see, if you look at all the mucormycosis paper in the literature, no series is greater than 15. The largest Japanese series is 15. Is it shocking?
Shocking.
And here we are doing, maybe the Nagpur does more than, I don't know, not exaggerating, but at least that number every day from somewhere, if you look at all the people together in Nagpur, I'm sure we are doing that in one day rather than waiting for the whole year to publish a series.
But we
are collecting data, we have made formal guidelines, and then we are taking biopsy. Say, for example, open versus closed discussion, big discussion always, whether you will do endoscopically, whether we will do openly. Now, what are the guidelines where you say, no, this patient requires open surgery? That this patient does not need open surgery. Now, can you also factor into that the training of the surgeon? You see, the surgery which you saw, what you demonstrated, cannot be done by a surgeon who is not optimally trained into it, but has to do something. He should not get a wrong sort of a idea or some kind of a guideline because boss does this, I should do it. If I don't do it, I'm a small person, I can't admit it, so I'll still do it. Not like that.
Very true.
It should be a learning pattern also. How quickly can I learn? Because we don't have time. You see, Mucor will be finished in another 15 days, maybe another month. But before that, can I adopt the technique which was
create a database to really give guidelines?
Right. Hopefully we'll do it.
But one good thing what you mentioned was that in Pune, I heard that 25 ENT surgeons were to be specially trained to do this kind of Banker's procedures and advanced fest surgeries. Another thing is that why, I mean, every other day we find another committee being formed, advisory committee. Recently, I heard there was another advisory committee in Nagpur on Mucor, and where Dr. Kapre doesn't figure in that list. So I'm shocked. So anyway, let's go ahead with the discussion. This is not personal compliment to you, but yes, this is where the government is wrong.
Yeah, my question to Kapre sir.
Yes.
Sir, what is the reason of the increased mucormycosis in this second wave? To all faculties also. What is the reason? Probably what do you think, sir?
We do not know. But the factors which are contributing are probably one, which is some down dysregulation of the immune system where the virus is little changed. So it is hitting the immune system because it's an mRNA virus. So maybe that's one thing which everybody keeps on telling. I personally feel injudicious use of antibiotic because you see, you look at the prescriptions we get, they all receive meropenem, they all receive tazobactam, they all receive I mean, you name an antibiotic they receive. They also received antifungals which are not effective against mucor. You see,
Yes.
most of them will be given fluconazole. Most of them will lead into a very, you see, I don't mean to sort of be any sort of against anybody. One of my age gynecologists who came back from isolation in a COVID hospital, and her first reaction was, "मी पहिल्यांदा अंघोळ केली." You see, look at it. That means that lady was in such a hygienic state that she has no facility for a bath. She has no facility. Leave apart all the oral hygiene and the nasal hygiene. So that's another very contributory factor is hygiene. The second thing which is misled by us, and we follow the Western books without understanding, is toothbrushing. Be honest, how many of Indians toothbrush? And then you tell them every 15 days you change your toothbrush. So let's be guided by, they all use misri, they all use manjan. So they be an agricultural source of mucor. They also use fruits. You see, हमने यहाँ क्या होता है, बीमार पड़ गया तो क्या है, उसको अंगूर भेजना है, उसको सेब भेजना है. अरे अंगूर कहाँ पे थे, सेब किधर थे, उसके ऊपर क्या था, धोए थे. There are lots of factors, but the most relevant is injudicious use of antibiotic. Probably steroid were used in the first phase also. Some down dysregulation by the mRNA, which is a new mutation in the virus, maybe. But truly speaking,
Dr. Kapre, 30-second interjection on steaming. The amount of steam people are taking, is it causing the altered cilia and altered nasal epithelium?
Yes, probably does.
8 to 10 times a day. I mean,
they damage the epithelia, they damage the cilia, they overdo it.
So why can't we have stop it? Because this is something which is easily done.
Yeah, should be.
Every doctor says, take steam, take COVID position, take steam, take COVID position.
Also the injudicious use of all kinds of, I would say, I just slipped my mind because it was going through me. I was quite keen on it, is to not regulate their glucose levels. It should be mandatory that all the people who are into the COVID treatment, they should have their glucose registered at least not twice, at least once a day to get some recognition of hyperglycemia, which is probably one of the biggest thing, and the ferritin, which also is a big thing for the mucor.
Yes,
levels of ferritin, very high. And that is a sort of a feeder for the mucor. High ferritin and glucose.
Sir, my question to sir, does sinus debridement reduce the resistance to breathing, and does it decrease the post-operative ability of the person to filter out the microbes that will have direct access to the lungs after the sinuses have been cleared? Because I realized that this pandemic has been a humbling experience. First, the patient is out of COVID, and next he lands up with mucor. And what is next for this patient? What kind of precautions do these patients have to take after undergoing sinus debridement? Do we ask them to wear indoor mask all the time? Do they have to wear better quality mask? What is the immunization schedule? And what is the kind of life expectancy these patients have? Are they more susceptible for the mucor in the next wave? What are your thoughts about that, sir?
As I said, we are learning. And one of the things reassuring is that not many are bilateral. Most of them are unilateral. So they still have one side which is fairly normal. Secondly, after various kind of debridements which people undergo in the past for other indications like infective chronic sinusitis or nasal polyposis, there is not much of a recognition of immune failure, and they getting a lower tract infection, like they're getting more of bronchitis or more of asthma or more of lung disorders or some lung diseases. There is no real scientific evidence based on that. So nothing not to panic. But what happens after this, we are not really sure. But I'm sure if it is a unilateral case, then nothing to worry. Only what they will suffer for some time will be severe crusting. They'll get a lot of crusting, and they will take care of their crusting by you saw my technique in the first slide that I actually put a Ryle's tube, but I put the Ryle's tube into their maxillary sinus so they can flush it themselves. Cheapest way of irrigation, don't depend on nurses. They may have to do that. Maybe there is some going back to Jalneti. I do not know, but I don't support Jalneti. Don't get me wrong. because more like that.
I start doing it.
Yes, the water they use should be not the that Ganges was when the Jalneti was prescribed so many centuries ago. It's all polluted. It's a potable water which we get from the tap. So tap water should not be used, but sterilized water of any sort or saline sprays we get, they may need to use it for a little longer period than average and be very careful in summer. Not so much bad in the winter or the rains.
Sir, one
I
question.
have a question for Nitin sir. Because we have both the facilities, one is COVID and one is non-COVID. Sometimes when the patient comes with mucor, because we get mucor in COVID patient as well as post-COVID. So suppose he is coming with mucor in 10 or 12 days, then because we all suppose that at 10 days, after 10 days, the COVID is not infectious and probably is now post-COVID. But when we do RT-PCR, yes, it does come positive. And then again, that pose questions whether he's still positive or it is because of that virus, the RT-PCR is coming positive. So what you suggest, how, whether we should use antibody test and how it should be used to get this patient admitted to a proper facility?
No, as per CDC, USA, because they were the first to put an all evidence to all these things. So they always say it is time-based, it is not test-based. So you should never look at RT-PCR. In my hospital also, when we shift people from COVID to non-COVID, it is all time-based. So we shift mild cases from COVID to non-COVID after 10 days, moderate cases 14 days, and severe cases after 20 days. So it is all time based. Please do not look upon to PCRs, because PCRs can be positive for 3 months. So they won't take you to any direction. So when patients come in, immediately within 10 to 12 days, they can be still infectious. So I think that is the time you have to do all respiratory precautions. And if they have received antivirus like remdesivir, there's a chance that probably the viral replication has come down. So remdesivir, the problem with remdesivir is that it reduces viral replication, it reduces the duration of hospitalization, but it doesn't add into the mortality benefit. But if they have received remdesivir, there's a chance that the viral replication must have gone down. So probably if they come below 12 days or 14 days, then you have to do all your respiratory protection. Respiratory protection, I'm talking about, not talking about PPE. So it is a respiratory virus, spreads through the aerosol and it's airborne, and you have to have the good respiratory protection. So even if the patient doesn't wearing mask, it is you should wear a good respiratory protection. I think that is important.
So any role of
and probably when all of us are actually vaccinated with 2 doses, I think we should not worry. We should have a good mask, vaccinated 2 doses. We are pretty protected.
Any role of antibody testing, sir?
Antibody testing is, if you ask me, it is very, very important to diagnose the post-inflammatory disorder of COVID, the MIS, the adult inflammatory or pediatric inflammatory. Otherwise, antibody testing, I mean, antibodies start rising. It is very, very variable. Sometimes it starts rising after 7 days. Sometimes up to 3 weeks, it may not rise. So it won't give you good direction to do antibodies. So just count the days. I mean, please ask the patient what days he had symptoms. Those symptoms can be anything. It may not be fever. Sometimes they have sore throat, and after 3-4 days they start having fever. So please try to count the days of illness. You can add 2 or 3 more days, because patients they do not remember. They'll say, "Pata nahi, kali to hua tha, 3 din hue the, ab bhi fever hai." No, they will all that. So please try to, my first question is all COVID patient is this. And then I start thinking what to do with them, to do a scan, do antiviral, admit, hospitalization, COVID, non-COVID. So it is all time-based. So please carefully find out the time.
Thank you, sir. Sir, Milind, sir, can I ask you something? Sir, when we use amphotericin retrobulbar injections, sometimes means I have used some, but sometimes they have stopped the disease. Sometimes they could not stop the disease. Suppose we are following up these patients after doing retrobulbar injections, and there means, what is your experience, sir? How long have you followed them up? Whether the disease was regressed or it is just stopping the disease, and then how long to follow means, that is always a question.
Well, until a month ago, I had never used this injection. So now we are in the process of collecting this data. even the published literature is so limited that once you have, run out of all the options that have been described in the past, you do not know what to do. But what I can tell you is that you can either give those injections on a daily basis or an alternate day. Not more than 2 cc's of solvent should go into the orbit because you can have concerns with compartment syndrome. And what you need to follow up after that is the tenseness of the orbit, whether you are causing pressure on the nerve. There could be an option of measuring intraocular pressure, but that needs devices like tonopen, which is not easily available. And you could monitor either the clinical signs, which initially could worsen post-injection due to inflammation, or you could monitor the radiology. But as long as the vision is restored and you could do a weekly radiology in the form of MRI with contrast, you could give injections based on the past experience, which is up to 5. Beyond that, we will have to know by performing these injections beyond the recommendations to know whether they are of any use at all. But scenarios are focal involvement of the orbit where you do have contrast enhancement, or let's say the floor was involved and the ENT surgeon has also removed the floor and the nearby orbit, you are not sure what's really happening. They've done their best, but you want to still continue to inject into the orbit so that so the indications are vague. They could expand in future, but at this point of time, I can only mention what is published in the literature.
Sir, your experience about limited resection, if you have done in some COVID cases, suppose a patient who has already undergone FES in sinus surgery,
right.
Even maxillectomy, has some residual disease in the eye,
Okay.
and sinuses are all clean. So there is means no need to revisit sinus surgery. So
a lot of ENT surgeons say that debridement is not a one-time process. You may have to keep checking the sinuses, and there might be times when you want to either irrigate or you want to re-debride based on the collection. You could have missed certain areas like terapalpine fossa. But if you have focal involvement of the orbit, I would do a contrast enhancement. If there is lightening up of that tissue, which means your drugs are likely to reach there, you could manage it immediately. But if it is dead, then you might have to.
Dr. Tiwari wants to continue something? Dr. Rao?
Yes, sir. Yes, sir. I have a question for Dr. Nitin, sir. Sir, can mucor present in post-COVID patient as a indolent disease? And another question is, there was a slide in Dr. Ravi's sir's presentation that there were 24 samples of accentrated eyes, out of which around 20 patients had diabetes. So, can infiltrative mucormycosis present in patients who had no history of diabetes or other immunosuppression? Can it present in immunocompetent patient in that way?
I think this is the right question, and it is not about diabetes, it is about hyperglycemia. We are seeing a lot of patients who HbA1c is normal, they have no history of diabetes, but they have a lot of hyperglycemia. Sugars are, HbA1c is 5.9 and sugars are going like 400, 300, 350, and that is not being taken care of. So I think hyperglycemia is the most important thing over here. And when we realized that yes, hyperglycemia causing problems, we started doing HbA1c in each and every patient, and we could find so many patients who were not aware of their glycemic status. And in fact, their HbA1c is around 7.9, 8.2, that sort of. And even some of them where HbA1c is normal, but sugars shooting up to 300, 350 after giving steroids. So I think hyperglycemia is a very important thing, number one. Number two, this is in my observation. I don't know how many, all of you are doing a great job. So I am seeing mucormycosis like a disease where everybody wants to, do a radical surgery and eradicate the disease as possible. But in current pandemic, I could see a lot of patients who can be managed with conservative surgeries, who could have been given with managed with a good antifungal coverage. The moment this antifungal things has stock out of market, then the problem started rising. So the breakthrough infections, the relapses after even surgery, all those start happening after short supply of antifungal medicines. So I don't know. I think this is my question to all of you: that can we manage this type of disease in a less radical surgery or more conservative surgeries? And I could see some of the patients who got better with the without doing a lot of radical surgery, with a proper, because I am an ID physician, so my eye is on completely on antifungals, and so I keep giving the antifungals for 2 months, 3 months, and keep doing TDMs, and so that completely better. So I would really like to all of you to have a think about this.
Sir, can it present in an infiltrative way in an immunocompetent patient, somebody who had no hyperglycemia
Yes.
history?
Yes, we
Can
have
it?
seen those patients. There's no history of hyperglycemia. I have one patient who had fungal cyanosis, no history of diabetes, quite young, 23 years, not received steroids, nothing, no history of COVID. So I did his antibodies, and antibodies is positive. So I think COVID is a strong link. And what has happened in this wave in India is that probably this new strain B617 is driving the whole epidemiology, the whole transmission over here, which is causing more severe disease, prolonged hypoxia, requiring prolonged administration of steroid. So people are scared of that hypoxia. So I would really not agree the use of injudicious or indiscriminate use of steroids, because people are worried about hypoxia. I am worried about hypoxia, and people they go into cytokine storm, like next moment they're in cytokine storm. So people are scared, and they try to use more and more steroids to avoid that hypoxia, to prevent that ICU transfer. So I think that is the reason is causing more hypoglycemia. And I have only seen only one patient who have indolent jaw osteomyelitis because of mucor. It is an indolent disease. It's almost like this patient was admitted in February and is presented to me in May first week. So indolent jaw osteomyelitis because of mucor. So there's only one case. So, but pretty otherwise it's a classical presentation. They normally have they love orbital apex. We try to go to orbits all the time.
What about TOSI? I mean, are we linking tocilizumab also along with the mucor? Use of?
No, I don't think so. No, I don't think so. We have used a lot of tocilizumab,
It wrecks
and
your defense, and the mucor is seen in patients who have been given TOSI. I don't know.
No, because tocilizumab, no, it cannot happen, because tocilizumab is actually IL-6 inhibitor. It's a direct IL-6 inhibitor, and it remains in circulation for 16-17 days. The commonest complication which I have seen after tocilizumab is bacteremia. The patients go home, they get better after tocilizumab, they go home, they come back after 15 days with fevers, they have sepsis, they have blood cultures positive, but see, they do well with admission. They require another hospitalization, they do well. I don't think tocilizumab, because it is all about innate immunity. It is suppression of CD4 and CD8 cells because of the virus, and basically hyperglycemia. No role of humidifying oxygen and this and that. I mean, this will be very clear. The mucors cannot survive in the fresh oxygen. They cannot survive. So all this area of industrial oxygen and humidifier and all that is not right.
Dr. Nitin, is there any?
So in our hospital, we have discharged around 3,000 patients by now, 3,500 patients in my hospital, and we are a Joint Commission International Accredited Organization, and we have excellent air quality controls in our hospital. We have very good environmental controls, and we have only 2 patients have developed mucormycosis out of all 3,500 patients discharged from my hospital. So I think the most, because we have a full-time 2 endocrinologists who are around the corner, who keeps managing all the sugar of all the patients. By default, they manage all the sugars, and they look into everything. Most of the patients are on insulin, and sugars are top notch, and we have an excellent environmental air quality. So I think these are 2 important reasons where we do not see mucor in our discharge patients. We have operated around 73-75 patients in last 1 month of fungal cyanosis, only 1 or 2 orbital exenerations. So I think it is more of the variant causing more hypoxia, more hyperglycemia, more prolonged steroids, and at the same time, poor environmental air quality, which is causing, and of course steam. I think steam is, again, people are obsessed with steam. So I think the 3-4 factors are very, very important in this pandemic.
Dr. Nitin, is there any safe period or maximum period post-COVID after which mucor cannot get mucor? What was the
we really do not know. I am looking into my data, and I'm trying to look into other people in the Nagpur who have data. We are trying to look into that data. What is the maximum duration or average duration where mucor is presenting after diagnosis of COVID? We're kindly look into the data.
Yeah, we just want to share, sir. I got one patient more than 6 months post-COVID.
Okay.
It was.
Yeah, Ashish, we have got Professor Dr.
Yeah.
Rajesh with us. He has got a vast experience. He will like to put in a word regarding scenario in government hospitals for this mucor. Yes, sir. Rajesh Joshi, sir. Unmute your. Sir, you are unmute.
I'm not sharing my experience. In fact, I want to ask two questions.
Okay.
One is, what is the difference in the presentation of mucormycosis as far as eye is concerned before COVID and after COVID? Like Milind Naik sir must be seeing many patients now, and he must have seen previously also. That is my first question. And second is, when you will tell the patient that you are free of mucor?
Well, the difference between the pre-COVID and post-COVID is...
Can you be a bit louder, sir? Can you be a bit louder? Yeah.
Am I audible?
Yes.
Yeah.
Yeah, the difference between pre and post-COVID is predominantly the numbers. Earlier, we used to see these cases very rarely. These could be patients who are either having systemic cancer and there is immunosuppression, or organ transplants who are on immunosuppression, and you get an orbital cellulitis where you would not think about mucor immediately. So apart from the number and also this cluster of post-COVID raised blood sugars and the reduced immunity. So apart from this combination, the disease pretty much behaves the same. The microbiome, you diagnose it, the way you treat it. And the confusion about when to do exenteration has still remained the same, but probably right now we have a spurge of data where we probably might find more accurate answers.
Can I ask one question?
Sir, we can
Can
have one quick question, then we have to wind up, sir. We can have a quick question.
Can I ask this last question?
Yes, sir.
If on CT or on MRI we see that optic nerve is involved, or the optic nerve area around is involved, then it is quite possible that the mucor can extend into the brain, right? So in such situation, is it okay to do exenteration or enucleation to avoid that the infection should go up? This is very, I am thinking a lot about this question because R. Ravi has already shown us in his 4 cases, optic nerve is involved, perineural tissues are involved, and the mucus was going ahead, invading the nerve. And we know that dura is there, and along with that, it can easily go up to the brain. So in such situation, do we think that exenteration or enucleation or whatever, or the debridement in and around the optic nerve area is going to be the very good option? Dr. Madan Kapre sir and Dr. Milind Naik.
One second, Milind. The mucor has a propensity for vascular bones. So it invades the bone. It causes even osteomyelitis. So I mean, how much you can keep on removing? Go ahead, Milind. I just wanted to interject.
No, first of all, we need to remember that in these cases, we would rarely consider enucleation. I heard that term being used interchangeably with exenteration quite a lot of times.
Yeah, but
we are talking about infection going beyond the eye. So we are talking only about exenteration. And even if you see perineural involvement, whether an exenteration would really improve survival, this data is not known. So it's only speculation. You could say that probably this will save someone's life, or probably you are making him physically, cosmetically handicapped for life. You don't know which choice is better. Only time will tell that. But yes, if you had contrast enhancement and if that nerve is lighting up, probably your drugs are also going to reach there. So even if you may not be able to salvage vision, you might still be able to salvage a moving blind eye, which is far better than a prosthesis.
Very true. So shall we, I hand over the mic to Viral for the winding up, and I thank all faculty. They had given such lucid talks. They were open to discussions and they were open to accepting, our comments on this. Thank you so much. And over to Viral for winding it up.
Thank you, sir. Sir, we have got lots of questions also pouring, so I will send it to respective faculty by email. They can answer them at their convenience, sir. So, but we are very strongly pressed for time. So I think it's time to wrap up the evening or late night rather. And I invite Dr. Smita Karandikar, Smita Upadhyay, Honorary Secretary of OSN, to make an important announcement, quick announcement. Please, Dr. Smita.
Good evening, everyone. Today we were able to conduct this webinar, the Black Code, under the aegis of Vidarbha Ophthalmic Society, thanks to the efforts of Team VOS, President Dr. Ashish Thul sir, Honorable Secretary Dr. Sean Chinchole sir, Chairman Scientific Committee VOS Dr. Viral Shah sir, Treasurer VOS Dr. Manoj Oberoi sir, OSN President Dr. Mona Mujumdar Madam, and Team VOS and OSN. It was wisdom we begged for, and it was wisdom which was very well imparted. Thanks to our prominent speakers for enlightening us. I thank all the senior members of OSN and VOS for guiding us and actively participating in the discussion. I hope to see you all soon on 29th May evening Saturday for oculoplasty webinar at 7 p.m. See you soon. Thank you.
Thank you so much, Smita. Also, we have got a couple of webinars, national webinar series continued in June also. So we have got 2 webinars coming up in June. We will be coming with you shortly with the details. And for now, the formal vote of thanks, I invite Dr. Sean Chinchole, Honorary Secretary of VOS, to please propose a formal vote of thanks.
It's great to hear from all the star faculties. Thanks to Milind Naik sir, Madan Karpe sir, Dr. Ravi sir, Sandhya Sauji ma'am, Nitin Shinde. Really a great talk. And thanks to Chairperson Dr. Prashant Agnihotri sir, Moderator Shivani Bide, then Coordinator Rahul Tiwari, Co-Chairman Yendi Patil sir, Convener Neha Deshpande. Thank you very much. Our expert panelists, thanks to all, Prashant Bavankwe sir, then Rajesh Joshi sir, Milind Chagole, and Ashish. And thanks to our ONS team, President Madan Mujumdar and Smita Upadhyay as a secretary, and Pallab Kusumgar. Thank you very much, and really thanks to Viral Shah for chairing this session and as a chairperson and chairman of scientific committee. I would like to thank to our president, because of whom we are doing all these things, that's Ashish Thul, and treasurer also. So thanks to all, and thanks to Sun Pharma for our AV support. So thanks to all, and wish you all best luck and good night. Thank you very much.
Thank you. We are our next.
Thank you and good night.
Yeah.
Thank you all.
Good night. Thank you all. Thank you. Corona-free life.
Good night.
Good night.
Bye. Soon, physically.
Yes.
As soon as possible.
Thank you all.